Okay, welcome everyone today to the final pitch event for HackMedTech 2023. My name is Jesse Ehrlich. I'm the program manager for the MedTech Talent Accelerator at McGill University. So this is the culmination of a 3-week virtual hackathon event. We're very excited for everyone to propose their solutions to this year's challenge. So just a quick note, on the MedTech Talent Accelerator, which is hosting this hackathon event. We're an NSERC Create program, and we're training industry-ready talent for the Canadian MedTech sector. So this hackathon is sponsored by an industry member. So the challenge this year is improving throughput of hospital emergency departments. And we're very proud to have partners this year, including our industry sponsors. So Click Applied Science is the main sponsor of the Hackathon Challenge, and as well as our clinical partners. So the William Osler Health System, Royal Victoria Regional Health Centre, and the McGill University Health Centre. So the parameters for today of improving throughput of hospital emergency departments is first optimization. So we're looking for teams to optimize the intake and triage, to the investigation and treatment, and the discharge or admit decision. And then the metrics to optimize are patient throughput per hour and length of stay in the ED. As for the solution, we're looking for teams to address how do you improve the performance of an emergency department with minimal infrastructure investment. And for the 3 points to hit are first, to describe the logical structure of the emergency department, 2, to describe the proposed solution and technology, and then 3, to discuss your plan for clinical or simulated testing. Today's judges are Jan Fossep from Click Labs, who is the Vice President and Principal Investigator, Dr. Anthony Robert, who's an Assistant Professor of Emergency Medicine at McGill, and the Assistant Director of ED Information Technology at the MUHC, and Dr. Prashant Falfer, who is a staff physician of emergency medicine at the William Osler Health System, as well as an Assistant Clinical Professor of Family Medicine at McMaster University, and Head of Strategy at First HX. The judging criteria for today are the solution description, the description of the ED structure, the testing plan, and the clarity and quality of the presentation. Before we get started, I'd like to thank our mentors who have helped support our teams throughout the past 3 weeks. So JC Kaufman, who's a research scientist at Click Labs, Anirudh Tomandram, who is an engineering lead at Click Labs, and Jessica Oraskovic, who is an R&D engineer also at Click Labs. We also had clinical mentors, so Dr. Ryan Tam from Credit Valley Hospital, Dr. Wayne Choi from Fraser Health Authority, Dr. Raphael Arichunian from McGill University, Dr. Stephen Rosenthal from the Jewish General Hospital at McGill, and Dr. Mark Bake, the IT Director of the Emergency Department at the McGill University Health Center. And finally, we'd like to thank our 2 guest speakers who gave special seminars during the hackathon event. So Dr. Noreen Kamal from Dalhousie University and Dr. Eddie Lang from the University of Calgary. And just a reminder, our awards for today are $2,500 for the first place team, $1,500 for second place, and $1,000 for third place. And so before we get started, I would just like to give a land acknowledgement. So McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples, including the Haudenosaunee and Anishinaabe nations. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which peoples of the world now gather. Okay, so to kick things off, we are starting with our first team, which is Code Blue Crew. Okay, please share your screen and take it away.
So you guys are able to see my screen?
Perfect.
Perfect, slideshow. Okay, there we go.
Perfect. Thank you, Ryan. So hi, I'm Chloe. I'm part of the Code Blue crew, and I will cover the rationale and background behind our solution. Yep, so we can move.
Yeah, I'm sure. Okay, there we go.
Okay, perfect. So each year in Quebec, 3.7 million patients present themselves in the emergency department, which represent around 43% of the province population. Nearly 10% of these participants will go home without being attended to. In large emergency department, 40% or more of staff time is spent caring for patients who are waiting for a bed rather than looking after new emergency patient. Of the patients that do make it through the emergency pipeline, 80% of them will be discharged after physician initial assessment. Of the remaining 20%, most of them would be admitted as inpatient. They will be transferred to intra-facility unit, or they will leave by themselves after triage. Delayed discharge is a major roadblock to emergency department flow. It delays caring for patients being admitted. It also increases the risk of adverse events, including medication errors, mortality, and infection. And it also increases the length of stays and associated costs. Physician orders are almost twice as more likely to be delayed or missed in emergency department as compared to inpatients unit. So the communication between the various body of healthcare provider represents a major challenge to better discharge rates. Delayed discharge can cause bed block. So a key waiting period of wait time for emergency patient is the time from the physician initial assessment to the departure. The Canadian Association of Emergency Physicians recommends 2 hours at the median, but this target consistently fails to be met. A primary contributor to wait times during this period is a lack of available beds, which is partially attributable to administrative inefficiency. Providing physician and discharge personnel with patient-specific, evidence-based information on the extent to which monitoring is required can simultaneously ensure that patients in need are provided with beds and not discharged, and that patients objectively ready to be discharged can make room for those in need.
All right, thanks, Chloe. So I'll be covering our solution, which is really a system for optimizing inpatient bed allocation. And so from a high level, bed block can be seen as a mismatch of resources between high demand from emergency inpatients and a low supply of hospital beds, which are a limiting resource. And so we have two main strategies to improve this. And so the first is to improve bed allocation decisions. And so within a patient's flow through the ED and hospital, there's, I guess, two major decisions that need to be made. So the first is to prioritize emergency inpatients who are most in need of a bed to ensure they're admitted. And there's also a discharge of hospital inpatients who are least vulnerable or less likely to be readmitted, so improving the hospital outflow. And to implement this, we designed a clinical decision support system that predicts patient risk and aids hospital management in prioritizing bed allocation. The second part of the strategy is to improve coordination between the emergency department and the hospital. And to do this, we designed a dashboard that tracks patients and resources in real time across the emergency department and hospital. And it can be used by hospital management to coordinate admission and discharges. And so putting this together, we have this clinical decision support system integrated in a dashboard that makes suggestions for which emergency patients to admit and which hospital inpatients to discharge. And so taking the first piece, so we want to predict hospital admissions. And so there's this paper in 2022 that used an XGBoost model to show they can accurately predict hospital admissions within 30 minutes of an ED visit. And so what they used is they took as inputs patient demographics, lab results, medical history, vitals, as well as triage notes, and they looked at different time points to see whether these inputs could predict their admission to the hospital. And they saw that over time, obviously, their prediction for hospital admissions was improved, but even within 30 minutes, it was fairly accurate. And so what this can do is it can facilitate triage and fast tracking of patients who are in most urgent need of being admitted. And this model can also identify patient features that are most relevant for admission decisions to support making these decisions for physicians. So for example, it can look at white blood cell counts, glucose levels, all these parameters. and inform the decision based on that. So the second part of our model is predicting readmission risk. And so you might imagine that discharging hospital inpatients too soon risks patients needing to be readmitted. This is very costly, it's resource intensive, it's an indicator of poor care quality. And so various machine learning approaches have been successful for predicting readmissions of patients, and usually they're broken down either into predicting readmissions for specific diseases like diabetes or all causes. But one problem is that it only makes these predictions at a given time point. And so this paper here in 2022 used survival analysis along with machine learning to predict readmission time course. So you can see in this graph here, the readmission probability on the y-axis, number of days on the x-axis. And you can use this to kind of see how a patient's vulnerability evolves over time. And from this, you can do a dynamic risk ranking to stratify patients based on likelihood of readmission. And you can also calculate a elevated risk period based on this risk threshold for when a patient should stay within the hospital or when they can be discharged. And so putting this all together, this is what a schema of our hospital dashboard would look like. So it's for a given hospital, it has information from both the emergency department and the hospital itself. It can track occupancy, wait times, as well as the volume of patients currently in the emergency department, as well as expected admissions. On the hospital side, you also have occupancy metrics, as well as long stay patients and anticipated discharge. But importantly here, you can also look at a patient breakdown, a patient level view. And so this can track patients according to where they are in the process, their length of stay, their severity index, but it can also, so our model can make concrete predictions whether a patient should be admitted or not admitted. It can also come up with a risk score out of 10. The more risk, the more likely they should be admitted, and then it can also arrange them in a queue. Same thing for patients in the hospital. So it can look at discharge status, should they be discharged, what's their risk, as well as their discharge queue. And so from a more kind of concrete perspective, how would an ER doctor be using this dashboard? So ultimately, they're going to be using it to decide whether to admit a patient based on their risk score. And so you might imagine that they can click on a patient, they have all this information, demographics, medical history, triage notes, etc. But what of these factors is the most important for making this admission decision? And so our system will highlight those factors. Maybe it's they have comorbidities that are very serious, or their age, or their testing. So what are the most important parameters for making that decision? Now, from a hospital management perspective, what's key here is that they can be tracking what's going on in the emergency department at all times. So if there's a lot of patients waiting to be admitted to the hospital, this can trigger a discharge process for patients that are currently inpatients in the hospital, but are relatively stable and have low risk of being readmitted. And so again, this can take a given patient, it can look at their, it has a link to all their medical history, and it can highlight the factors showing that they've been stable for X amount of time, that they're at low risk of being readmitted. And so really putting this all together, we have this integrated clinical decision support system dashboard that can ensure the right patients are allocated to beds at the right time. So what it inputs is it takes in patient data from either the emergency department or the hospital. It runs this through a model that makes a prediction of whether to admit an ED patient or to discharge a hospital inpatient. And this is used by physician or hospital management to make more informed decisions based on all available data. And so some further improvements to this can include automated patient reports to facilitate discharge. So this can update medications, referrals to specialists, etc. It can also coordinate hospital discharge to improve bed turnover rate, because sometimes it can take quite a while before a patient is actually removed from an inpatient bed to when a new patient can actually get in there. And so finally, just how we want to test this. So there's three, I guess, aspects we want to test. First is the clinical efficacy and performance of the model. And so these models are generally validated on retrospective data that's already been collected in a hospital. This can also be validated by expert clinicians to see if the predictions it's making are in line with clinical guidelines. These models can then be pilot tested using real-time streaming data to make sure they're continuing to make accurate decisions. And key outcomes of this implementation include improving a patient's prioritization, their hospital or ICU admission, as well as mortality. Obviously, we also want to improve wait times. And so we can look at the length of stay measured for emergency department patients as stratified by acuity. And here we really want to focus on the highly urgent, likely to be admitted patients that really kind of bog down the system under high pressure. We also want to measure wait times between physician assessment and hospital admission, as well as the hospital bed turnover rate. And finally, we can solicit feedbacks from the main users, which are healthcare workers and hospital management, to adapt or adjust dashboard features, and also consult them on barriers to implementing this solution in a hospital setting. And so with that, thank you for your attention.
Excellent. Thank you so much. So we now have a little less than 5 minutes for Q&A from the judges. So judges, please ask your questions.
So one question from this is Jan here. Hi. So I really like the solution and leveraging machine learning to do some prediction like that. The one potential risk, it's not really a question, it's an observation, is this would really optimize the flow if we end up having currently a lot of patients who are taking too long to being discharged, or patients who are not being discharged who could benefit from being discharged. On the other hand, and this is good for the patient, but not for the throughput, if we have a lot of patients who are being discharged too early because they are still above that high risk time window and should stay longer, we're going to improve the care potentially, but compound the problem of throughput. So how do you envision predictively ahead of time finding out where the problem lies? Is it people not discharged fast enough, or like, is there a way to anticipate this before testing?
Yeah, that's a good question. Obviously, like being able to track, this information in the emergency department and hospital, different things will be required at different times. So if there's a huge demand from the emergency department, this might expedite the discharge of patients, but obviously it's going to be a dynamic situation, and it might not be the easiest thing to predict ahead of time, but you can imagine, yeah, there's a trade-off between, getting patients through the system faster and not having adverse clinical outcomes, right? And so exactly kind of finding that's going to depend on emergency departments, it's going to depend on hospitals. So yeah, that's going to be something to be figured out by, I guess, the management in these hospitals. But thank you for your question.
Perfect.
Any questions?
One more quick question.
Yeah, I just wanted to ask about, you mentioned it briefly around bed turnover time as an opportunity for optimization. Could you explain how your model and your dashboard would help with that?
Yeah, so essentially using the survival analysis, you might be able to, so we plan to predict when a patient should be discharged. So one of the pieces of information is patient X is going to be ready for discharge in 6 hours, 8 hours, something like that. And essentially it can be integrated with a system that plans the bed turnover. So this many patients are ready to be discharged. It can coordinate resources, and obviously, it might not be a high priority to get those beds turned over quickly, but if there's a ton of patients stacking up in the emergency department, that's going to be a high priority. And so it can be coordinated that these beds can be turned over faster when need be. And it's just a way of tracking what's going on where. Does that answer your question?
Yep, thanks.
Thank you.
Okay, thank you so much. So we're going to move on to the next team now. So it's ER Hack. Please take control, and the floor is yours.
So I guess I'll start. So hello everyone, we are Team 5 ER Hack, and we are happy to introduce our solution to reduce emergency department wait time by developing a real-time information exchange platform named Care Connect. So there are tons of reports about how long ER wait time can lead to death and poor health outcomes. And as we all know, emergency department wait is too long, and this is a problem we need to tackle here. So indeed, research has shown that prolonged wait time at the emergency department are not only associated with decreased patient satisfaction, but also with increased morbidity and mortality. So with the data-driven intervention, we can equally distribute the workload amongst healthcare staff and actually help to bring down the ED wait times. So how does ER work? Upon patient arrival, they will go through triage by nurses, which is a primary assessment to group the patients based on the severity of their conditions. And then patients will be registered to collect their basic information and wait for physician's examination. After that, assessment and diagnosis, intervention, and treatment will be done by physician during the process of care, and eventually, patients will be determined to be discharged or admitted. There are two main bottlenecks lead to the long wait time during the flow. The first happens while patients wait for examination by physician after the registration period. And the second one happens when a patient needed to be admitted and the patient had to wait in the ED until a bed upstairs is freed up. So studies have shown that there are rising ED visits from 11.7 million to 14 million in the past year, in which 65 to 70% of patients are discharged at the end of their ED visit. And the majority of discharged patients stay for 7 hours, while admitted patients can stay 40.7 hours.
The emergency department serves as a safety net for the patients who are experiencing sudden and severe medical problems. Patients with non-urgent or chronic medical conditions are often better served by primary care providers. However, due to the lack of primary care, ED still becomes the first point of contact for patients who cannot go elsewhere. According to the Canadian Community Health Survey 2019, 14.5% of Canadians are without a regular family doctor, and this number reaches 21.5% in Quebec. In addition, admitted patients in the ED often need to wait for a bed outside of ED because hospital beds are operating over capacity. Bed blocking is an important issue at hospital. One of the major reasons is that patients who need an alternative level of care cannot be transferred appropriately because long-term healthcare facilities are full. As a result, the ED is caught in the center where more patients are inflowing while admitted patients wait longer to leave. We look deeper into the kind of patients taking up hospital beds. Two major categories are scheduled surgery and ALC patients. ALC patients can take up to 10 to 15% of the total hospital beds. In summary, the blockage we see in the ED is the tip of a much larger problem and will require a multi-level integrated solution. To solve the service problem of ED overcrowding, we can increase ED efficiency and optimize patient distribution across different EDs. To continue to improve ED conditions, we must improve the operation and communication in hospitals and between healthcare facilities. And finally, fundamental changes can only be brought about by increasing healthcare resources for society as a whole. There is no short-term solution for changing how healthcare system operates, and increasing healthcare investment is a long-term process. As such, we will focus our effort on tackling the immediate problem of ED overcrowding before moving on to the next stage. We'll start with optimizing ED workflow, which will have a high impact on 70% of patients who will be discharged.
Perfect. With the issues mentioned by my teammates, we present our solution to the issue, the Care Connect system, which optimizes the connection between ED to patients and also ED to ambulances. Next slide. Care Connect system consists of two major interfaces. First, patients to ED, and the other one, ambulances to ED. On the patient side, it directs patients to the optimal ED for them. And also on the ambulance side, it increases the efficiency of connection between ambulances and ED, and it directs them to the optimal ED for them. And on the other hand, and on the ED side, it provides them with the estimated time of arrival of the patients, and also would further helps them to predict the surge or patient inflow. And to achieve all this, we will get initial data from each compartment in our model, input them to the Care Connect. And regarding the information, ED departments would provide number of beds available, number of staff available, and the number of staff available required for bed to be considered as a functional bed. And obviously the current number of available patients at the ED. And on the patient side, patients would provide their location through the application and the primary reason for going to the ED, which this would help EDs have a rough estimate of the type of incoming patients to their department. And ambulances, on the other hand, would also assess patients quickly. And based on their assessment, they will, and the assessment input to the Care Connect, they will either be directed to the closest hospital or to the optimal hospital for the care required. Next slide. And regarding the feasibility of the development of our system, the number of beds, number of staff, and number of staff required per bed, along with the number of patients existing at the ED, are already data that could easily be accessed and exist, so that it could easily be easily and fastly implemented in our Care Connect system. And accordingly, with our availability defined index at EDs and combining it with the info obtained from patients and ambulances, our Care Connect system would be able to combine the input data and suggest the optimal ED for them to go. Next slide, please. And regarding the efficiency of the system proposed, automated systems developed so far, like SearchCon and EACL, has shown promising results in reducing the waiting times in the ED. For example, SearchCon has reduced the ED waiting time from 104 minutes to 42 minutes, despite the 25% increase in the patient inflow. And therefore, we are optimistic that by integrating these data easily, which are easily accessed, and developing the Care Connect system, we will be able to decrease the waiting times at the ED significantly.
There are some important things to be considered when launching the Care Connect system. First, we need computational power and storage resources, maybe from a cloud, to real-time estimates. The data storage needs to be secured. And we also need to make sure there's automated data collection and validation to collect real-time data from healthcare staff. Lastly, to implement the Care Connect system, we need the government support. So to test and run the system, we will first construct the essential features, i.e. suggest patients at ED to go to, that the patients pre-register, and also send real-time info to ED. We'll start from the city and test efficiency of the Care Connect system by measuring ED wait time for the first 12 to 24 months. With successful implementation of Care Connect, we will be able to reduce triage registration time from 10 minutes to 5 minutes. With saving at least 5 minutes for each patient, this will result in a total of 48,600 hours saved amongst the 40 million ED patient visits across Canada. In summary, Care Connect helps distribute patients amongst hospitals to create equitable workload, improve coordination, planning, speed up patient care, improve system preparedness in response to research, and lastly, improve system transparency. In a long-term future, though, Care Connect can also be applied to other layers of healthcare system to help assist data collection and sharing amongst hospitals and other healthcare facilities, which can help to promote remote home care for LLC patients. And with successful long-term implementation, we will also be able to create a huge transparent network across all healthcare resources, amongst patients to ED, ED to ambulances, and from hospitals to hospitals, and eventually integrated with another layer, such as long-term care facilities. And with that, I would like to conclude our presentation, and if there are any questions.
Excellent, thank you. So questions from the judges?
Yeah, I can start asking the first question. based on your perspective, your algorithm can direct the patient to the right location based on the ED situations. How likely do you foresee patients adhering to that recommendation?
I think if it's an easy app that allows them to have easy access and it saves times on both ends, not only the ED end, but also the patient end. Like all of us now are so used to pre-registering, like calling an Uber, right? Using your app to look for the real-time data using Google Maps. So it can also be easily accessed by a lot of patients who will quickly do a search and then call it in a convenient way, because everyone has a phone. So I think it's if this is available tool, it can be easily picked up by people in this case.
Okay, I think it's a good thought. Keep thinking on that. I think the psychosocial aspect of any new technology in healthcare is actually very complex, but I think this solution has potential. Thank you.
Okay, any other questions from the judges? Okay, very good. So thank you very much, Hack. Our next group is RamQ Revenge. If you're ready, please take it away.
I can't see anything, just FYI.
Yeah, me neither. There's a blurry screen of HackMedTech.
Yeah, there seems to be a lag. Just one moment. Thanks for your patience.
Okay, take your time.
Now we're seeing well. Thank you.
Adiada, you're muted.
Thanks. I wanted to take a moment to thank our team members. All of us made a real concerted effort to come up with a solution to enhance ED flow. So I just wanted to send a quick thank you to Group 6 for all the efforts we've made on our aspects of this presentation. So I'm going to do a general overview of how multifactorial in nature the issue is with ED flow. I was able to find a really famous schematic that was actually generated in 2003 by the Alpine modeling that shows some of the influx of problems that we're seeing that continue to be pervasive in ED care that's offsetting ED flow. And so if you move left to right from the schematic, you'll see a culmination of issues with the seriously ill not being properly triaged, in addition to conflicting issues with patients that have unurgent care, in addition to patients that are not having access to the healthcare they need. So patients that are on Medicare and Medicaid, which is more pervasive, of course, in the US. And then that's putting extraneous demands on the emergency department. So that in and of itself, I think, is the key indicator of what's causing overcrowding. And overcrowding in and of itself evolves to issues with lack of resources. And that doesn't just mean having issues with a number of beds or patients to clinicians in terms of ratio. It's also access to crash carts, access to any type of medical equipment that could be readily available if it's actually provided in an efficient amount of time. There's many patients, as I'm sure the physicians in the group know, that crash because of this major issue. So these are all factors we want to take into account when we're thinking of ED flow. And then this is also very pervasive at the Glen. The ED unit at the Glen has a lot of problems with hospital capacity, despite how huge the healthcare campus is. There's also issues with technological advances that are not in alignment with what you see in US healthcare. And what I'm alluding to is an inefficient EMR, so an electronic medical system, where most of the documentation we see isn't digitized, it's still human record. And that leads to the fallacy of human error, which is poor reporting, bad issues with summarizing patient cases, transferring that knowledge between hospitals, patients' reiteration of their own healthcare symptoms. So that seems to be the most pervasive problem, which we'll highlight a lot throughout this presentation. In addition to community resources, so access to education, kind of alluding to what I'm not sure which physician was speaking earlier, so I apologize in advance, but the psychosocial issues of not necessarily understanding or having app literacy or understanding how to get access to the healthcare they need. So that's also something we want to take into account as we present our solution. So I try to take let's see if it works. I try to take an academic approach to actually looking at the literature and the solutions that are readily available, because obviously this is not a new problem by any means. So I try to frame my systematic review question by PICO. So for those people that don't know, it's population information component operation for identifying a smart question. So a measurable question that can identify what's the actual issue with ED flow. So what I used in my database is I was trying to look for the most efficient innovations to improve ED flow. What are those barriers and facilitators to actually implementing ED flow, which I think is something we're not highlighting enough in the current literature. I looked in PubMed, AIMBase, and the Cochrane Library. I tried to use, for those people that don't know, medical search terms, it's called mesh terms, and use the Boolean operators to make sure I could kind of accrue any of the articles that weren't necessarily properly indexed in all databases, including, of course, the grade literature search. The most, obviously several hundred articles popped up, and what seems to be the most pervasive problem and a consistent theme throughout all the articles I saw was an issue with technological advances. There needs to be enhancement in our EMR systems, and there needs to be enhancement in how we're communicating necessary healthcare for our patients. And so we'll introduce some solutions to that problem. But before we do that, Kevin is going to highlight some of the answers he got from the data.
Thanks. Yeah, so we analyzed the data set that was given to us. We were interested in what is causing these extremely long wait times and where the inefficiencies are. So the main metric we looked at was total wait time in the emergency department. So we plotted it as a histogram. So actually, if you look at this histogram, this bin here means that approximately 6,000 patients waited for about an hour. And we looked at these distributions to try to find underlying causes. So what's actually really interesting is it looks almost like a Poisson distribution, but it has this extremely long tail. So we wanted to find out why. And next slide, please. So you can break up that distribution into different demographics. So if you look at it for different age groups, you can see the tail of the distribution actually grows as the patients are older. So for the 65 plus age group, you can see it has a really long tail. So we wanted to know why again. So if you go to the next slide. So you can also group the data by disposition of the discharge. So it turns out that patients who are admitted to the hospital have extremely long wait times. So you can see here the distribution of between when they arrive in the ED and when they get their disposition discharge is normal looking, but when they actually leave the ED, sometimes it takes multiple days, and this disproportionately affects the age group 65 plus. So that's what creates those crazy tails. So what happens is patients are boarded in the emergency department. There isn't space for them in the hospital upstairs. So the nurses, who are typically understaffed, have to take care of them, and they can't treat incoming patients. So this leads to everything slowing down overall. And this was talked about by many of the seminar speakers and physicians that we spoke to. So there seems to be a real issue with patient flow for this particular demographic. So my teammates are going to talk about some solutions that we're considering for this, including potentially diverting patients away from the emergency department and to more appropriate forms of care. So Suijian, take it away.
So our solution is we have developed an app to increase the ER throughput. So we have two versions of the app, and one version for the patient and the other version for healthcare provider. So for the patient side, the main, going back. So as you can see, this is the homepage of the patient version of the app, and the main function of the homepage is to redirect patients out of the ER. So this homepage would allow patients, this app is readily available at the App Store and also were indicated at the ER. Patients can see using this homepage function that there are they can find a nearby walk-in clinic, urgent care centers, pharmacy, and they can even book an appointment with their primary healthcare provider or have a virtual consultation with a doctor that is readily available online. And the second main feature of this app is the ER function over here. So the ER function would allow the patient to find out the nearby ER, and it will give an estimated wait time of each ER. And for example, looking at the first nearest available ER at McGill Hospital, this app would indicate that there is an estimated wait time, administration wait time approximately for 3 minutes, and an estimated wait time to see a physician, which varies longer depending on the severity of case. And after clicking the navigation tool, the patient is able to access a step-to-step navigation to the hospital. Once the, once a patient click on which hospital they would like to visit for the ER, they are able to instantly update their symptoms and self-report medical history to the ER, and therefore this would help in facilitating the triaging process. And once they are registered and admitted to the ER, this app would allow the patient to access to their triage information, and also it can show whether their labs, tests, and imaging is pending or is it done. And this app also allows to have a discharging plan beforehand, therefore helping the outpatient process. Once the patient is discharged, they are able to access to a page where it reminds them for follow-up, having prescription reminder, and also booking a follow-up appointment with their family doctor. This app would also allow the patient to complete their medical records by self-uploading their medical records to this app, which leads to the third main function of the patient side app, which is medical records. So having a complete medical records would absolutely help the workflow of physicians and the healthcare team. So this app would be able to sync with the medical record system of the ER and have a very complete version of a patient's medical records. The patient is also able to upload their medical records themselves, and this app is able to organize it in a way that is very concise and searchable for the patient, for healthcare provider to assess. And then we have the healthcare provider version of the app called Efficient ER MD. So the main function of this app for the physician side is patient tracking. So this app would rank the patient in the admitted patient in the ER based on their severity level according to the CTAS categorization, and also provide a brief summary of each patient's reason of visit and their lab results. And if a patient click on a certain patient, they are able to assess the more complete medical records and triage information of the patient. For example, in this case, the physician is able to see the triage assessment, analyze how's the labs, tests, and imaging going, and also they are able to order labs and imaging and request resources such as beds and researchers using this app. And finally, the last function of this app for the physician side is to increase communication, which gives us to the messaging part. So this part would allow physician to communicate with other healthcare practitioners such as nurses, pharmacists, especially for non-urgent issues when the healthcare provider teams are allocated in different in long distance at the ER. So overall, our app would allow to redirect the inpatient flow, especially for non-urgent cases. It would help to make the medical records for patient becoming more complete. It would allow the coordination of diagnosis testing and labs. It would allow the patient and healthcare team to plan outpatient process beforehand, and ultimately it would increase the efficiency of workflow of the healthcare team and communication between the healthcare practitioner. Yeah, thank you very much.
Perfect. Thanks so much. Questions from the judges?
Hi, Jan. One question about the part where the patient report their symptom as they are being directed to a hospital. I was wondering how we could prevent gaming the system. So I'm a patient and I don't want to wait. So I'm going to say, you know what, I have chest pain. And the algorithm would say that might be a heart attack, you get top priority. Have you envisioned a way to mitigate that?
Yeah, so first of all, this app would only allow the patient to upload their self-reported symptom into one ER they selected, so they cannot, register like pre-triage themselves in multiple ER. And secondly, this app could only give a heads up to the ER. It can't really like the nurses or physician or healthcare provider needs to like self-examine the patient before triaging, because there's absolutely no way of knowing the severity of a patient before seeing the patient condition. So ultimately, this app is trying to just give a better like keep the ER more updated, and which allows the patient to maybe speak less and let the patient, like the healthcare team, to work more efficient. So yeah.
Okay, no, I like that. I think, yeah, if it's after you select the app, then that makes sense. Okay, good. Thank you.
All right, still time for other questions from the judges?
Yeah, it's Anthony. My question would be, you look at the problem and I see that it's the coordination, the exchange of information, and you're taking a big bite out of it. You're essentially replacing or sitting on top of the EMR and everything. One thing that I was curious about is, if you look at the prediction of how much time to wait, how does the patient differentiate their problem and how much time they would wait? Because obviously, as Jan said, somebody comes with chest pain does not wait as long as somebody who comes in with a toe pain. How do you display that information so that the patient can decide which ER, what is that wait time that you displayed represent to them?
So I think one thing about the ER is that it's very hard to predict the waiting time for non-urgent cases. So our approach is, ideally for non-urgent cases, we would try to direct patients out of the ER, such as if it's a toe pain. Then we would try to let the patient use the home screen like function, which like they can see a family doctor or like go to a walk-in clinic instead of jamming into the ER. Oops, I was trying to find the home screen, but and the second thing is, if a patient absolutely needs to go to the ER, we couldn't provide a very accurate wait time. We can only suggest, based on the ER's real-time data, we can suggest the estimated wait time is like for a certain range of time. Like again, it's like estimated, and like for example here, it's like like the time is varies a lot, and we could provide based on like some algorithm, we can provide an average wait time. But again, we would state that this model is not 100% accurate, and your actual wait time is actually in this range of time.
Okay, thank you. Sorry, I missed one part. What is your testing plan?
So I think to try this app, we absolutely need to try to work it at least in one ER and see how it goes, and potentially, yeah, go ahead.
Yeah, we'd have to do some type of beta testing, and we'd obviously have to get consent from all providers. I mean, we'd have to, like in the US, I've worked on something like this, and I had to get, it was essentially a study. So I had to get like IRB certification, and I was registered as a study, and me and a number of, I was a coordinator on the study, and a bunch of principal investigators were a part of it. And we integrated that information with patients that were coming into the ED with like, it was a beta test on using, at the time, instead of an app, it was using watches for actigraphy data. So I would presume it would be the same type of pipeline where it'd have to be like a clinical trial, it'd have to be some type of test in that nature, and then see what comes of it. And I would presume if it's published, then we'd have some credibility to actually launch the app.
Okay, thank you. Just be careful that you can't really study at one hospital, because you're trying to give different information about different wait times and different EDs, but maybe your small region would be a place to start. Thank you very much.
Very good. Thank you so much. So our next team is Les Cinq Hacketeers. Are you here and ready to present?
Yep, we're present and we're ready.
Oh, excellent. Okay, take it away.
How do the slides look? Working?
Perfect.
Okay, awesome. Good afternoon, respected judges. We are Team 8, Les Cinq Hacketeers, connecting with all of you from Montreal. We will be presenting on an accessible, implementable, and cost-effective solution to increase patient outflow in the emergency departments of hospitals. We all have come across devastating news about the abysmal long waiting hours in the emergency department. This is a truly heartbreaking reality that can happen to any Canadian. In the emergency department, every second counts, and we as a team have come up with a solution. Our team first began tackling the problem by understanding the emergency department structure in order to discover vulnerabilities and areas of improvement. Patients come to the ED with different age groups and different complaints, and they often lack the history. From the William Osler health data, we found that non-ambulatory patients comprise of 75%. After the patients check in by filling forms, they are seen by a triage nurse who assigns an emergency level from levels 1 to 5. The mildly urgent cases, which is CTAS-3, comprise of 55% of all patients in the triage. Depending on the urgency of the medical condition, some patients are referred out, others are asked to wait longer, and urgent cases are seen by a physician who then authorizes tests. The ambulatory patients, on the other hand, comprise of 25% of all patients, and they are immediately sent for tests, and they are assigned a bed. Once a doctor develops a treatment plan, and once the patients are deemed stable, they are discharged by the doctor. My team and I analyzed the data provided from the William Osler Health System. We found that not only do CTAS-3 patients make up the majority of cases in the emergency department, but they also spend the longest time waiting to see the physician. We believe our solution should focus around CTAS-3 patients. Coming back to the emergency department structure, we found that a pre-triage app, sort of like a check-in at the airport, can solve the problem of patient outflow through multiple mechanisms. I now invite Yuteng to introduce our app.
So we actually proposed two apps, Arrive ER and Arrive ER Scanner. So kind of like VaxiCode and the VaxiCode QR scanner. So on the patient side, we have Arrive ER. So key features are before arrival, patients will fill out a triage questionnaire and update their personal medical history. Upon arrival at the hospital, the app will allow check-in via QR code. In addition, it will also allow patients to view current hospital wait times. So beginning with the wait times or occupancy rates, we drew this idea from the popular times histogram used by Google Places. When a patient opens Arrive ER, they will be able to choose a hospital via the Google Maps widget. They'll have access to information such as hospital hours, distance from their current location, and average wait times. So average wait times is actually already implemented by the Albertan government. So we think this will help patients make an informed decision about where they're going and perhaps spread out the traffic, at least during non-peak hours. And once they select their desired hospital, they will click on the complete pre-triage button, which will take them to a 5-minute questionnaire. So this questionnaire will contain the same questions that they would get asked by a nurse in person. So this information will then be submitted to the patient's hospital of choice, along with their medical history, if they have this updated already in their profile. So this would potentially also help with the medication prescription down the line as well. When the patient arrives at the hospital, the nurse will scan their QR code with Arrive ER Scanner, and they'll be able to draw up all the information that has already been pre-sent to the hospital. This information will then be patched into eCTAS, which is already implemented across several Canadian hospitals. And it's an AI that electronically scores patients' CTAS levels, but ultimately the nurse has final say. So if we take this even a step further, perhaps during off-peak hours, nurses can look through pre-check-ins and determine CTAS levels before patients even arrive, and be ready for them when they do.
Now, we were actually able to find evidence to substantiate our idea to tackle pre-triage to increase efficiency of the flow of the emergency department. So Coyle and colleagues in 2019 showed that, in fact, self-check-in kiosks can be implemented effectively in the emergency department to improve patient identification time and queue patients for triage. So in this study, 2 self-kiosks were available at the Sunnybrook Research Health Center every other week for 10 weeks, where incoming patients were able to scan their health card and enter the main reason for the visit to the emergency department, either from a predetermined list of common reasons or enter it by free text. And so close to 900 patients, so about half of all incoming ED patients in this period of 10 weeks were used these kiosks. And overall, of those who had the possibility to use them, 97% of those arriving to the ER when the kiosk was open were able to use it and to self-check-in with them. So the first outcome in this study was time to first identification. So this was defined as the interval between arrival at the emergency department and identification in the hospital system. So this is what this graph shows here from the paper, that in fact they were able to show that wait time was significantly reduced by close to 14 minutes for people to be entered into the hospital system while using this self-check-in kiosk. So we were quite inspired by the results and thought about what if going from 1 to 2 kiosks, we would actually go to having multiple kiosks available, similar to the kiosks available at the airport to self-check-in with our luggage. And so going from that idea, we were imagining that what if people all had access to something similar to a self-check-in kiosk, to an app on their own phone. And so we devised a strategy to actually test this idea. So since it wouldn't be feasible nor ethical to just look at the app implemented in one hospital, we thought that it'd be best to look at different neighborhoods of various socioeconomic backgrounds as well as cultural backgrounds in a large city. So we took an example of Montreal. We were thinking of having the app available every other day, and this maybe for something similar as the study we were looking at, so 10 weeks, so 2 to 3 months, and then look at if there's any difference in the time to identification, so time that people were entered in the hospital system between days where the app was available and days where the app wasn't. And so advertising for these app in these boroughs would be done by through social media, TV, and radio.
Since we are proposing an idea of healthcare app, our app will comply with the current federal and provincial regulations and ensure that the patient's privacy and security is maintained. Also, we intend to make our app more integration friendly so as to integrate with other systems and features to make our app user friendly, and also streamline the pre-triage process to ensure a smooth healthcare service for our patients. For example, we can integrate Logibeg, which is deployed around 60 healthcare institutions in Quebec with Arrive for improving the healthcare access to our patients. Next slide. We estimated that the cost of our app based on the ArriveCan app. Though the cost to develop the app seems to be bigger, this is a fraction of what Canada uses for its healthcare, which is about $300 billion in 2022, which is around $8,500 per Canadian. And so our app is developed for a long-term purpose, and we can still reduce the cost of our app based on the developers we choose, the service we use, and other factors as well. We also have provided the timeline as well, and we assigned 3 weeks for planning and design, which is what we did in the past weeks in the hackathon. Next step is to develop the app itself. And once we develop the app, we test the app with our private healthy audience to test the features, the user interface, and everything, and then get their feedback. Once we get the feedback, we will do a pilot study, as Carla mentioned 2 slides before. We get the data and then modify our data based on the pilot study we do. And once all the necessary modifications are done, we deploy the app in short period of time. And so overall, it takes around 1 to 1.5 years to develop this app. And it'll be improving our healthcare streamline much better. Over to Ellie.
As a successful example, I can mention digital check-in, ER Express, to register, check-in, and manage patients at their facility. ER Express include a virtual waiting system, making it easy for patients to see their place in line before arriving, and so reducing wait time for everyone and increasing patient satisfaction, as you can see.
So the main rebuttal we thought that people would have against this idea, which we also considered ourselves first as well, was, what about people of older age who will probably not use this technology? Well, in fact, ER Express, as Ellie just mentioned, did an internal study, and they showed that what actually predicted the use of their self check-in feature was if people had smartphones or not. And so in their study, they showed that over half of people over 65-year-olds have own a smartphone. And looking at the William Osler Health data, we saw that only about 20% of patients were actually 65 years older. And as Ali mentioned earlier, 55% of incoming patients are in the CTAS 3, which is who we're trying to target. And so even though some people will not be using the self-check-in app, we think that most people will, and we think that this would be overall a quite feasible solution, as well as a solution that could be easily implemented and would greatly increase the efficiency of the flow of the emergency department. So after these 3 weeks of intense brainstorming with together and discussions, we hope that our app solution could streamline the patient inflow of the healthcare system and hopefully spark future ideas for both us and everyone present here today. So we thank you very much for your attention.
Excellent. Thank you so much. Maybe time for one question from the judges.
One question on your slide, the one just before rebuttal. I think you showed a list where you could see yourself. Is this patient facing that screen? Like the patient would see the other names of the other patient, or is that for a physician to see?
No, that's for physicians.
Okay, okay.
For physicians.
Okay, so I mean, just okay.
Yeah, that was just it was just the example photo that we found for ER Express.
Yeah.
But in Arrive ER, it would be like privacy is important, so no one would have access to anyone else's information.
Perfect. So I misunderstood that one. Great. That's it. Thanks.
Okay. Any other burning questions from the judges?
Yeah, I just wanted to ask what metrics they would be looking to improve. Like, what metrics would improve most likely from this type of, or do you expect to improve in this type of an application?
So we mostly expect, as in the kiosk study on slide 9, so we mostly expect the time to be checked in the hospital system that will be highly increased, as well, decreased, but just made more efficient. And also by having all these people, self-checking at the same time, it would also help the team manage their resources better by having an idea of the patients that are coming next. So we expect that pre-triage to be more efficient overall.
It would also help with I think down the line, like medication prescription, and also just like prescribing tests, because if you already have access to the patient's complete medical history, even if it is self-reported, I think that would help with facilitating like steps down the line as well.
Excellent. Well, thank you so much.
This pre-triage is a great idea that, sorry, I just want to comment that pre-triage is the current 811 system that we have in Quebec that says, go to the ER, any ER. So this is definitely a good step forward.
Perfect.
Thank you so much.
So thanks again. We have one more team before a quick break. So HackMed 10, you are the next team to present. Please go ahead.
Hello, can you hear me well?
Yes.
Hi, everyone. My name is Vaishali Mukherjee. I'm a student in McGill University. I am from Team 10. My team members are Arthur and Tanya. Many thanks to them for sharing their ideas and all the brainstorming we have done. So to start with, in simple terms, what is ED throughput? Like if the patient length of stay in the hospital or in the ED goes down, ED throughput increases. But in the ED, there are several steps in between patient arrival and patient departure. It looks like a linear process, but actually it's very complex because there are different kind of problems the patients come with. This is a pie chart we have from the 6 months ED data that was shared with us, thanks to them. And to tackle with different kind of patients, there is a CTAS system that we all know about. And from the same data, we have seen that most of the patients are coming into CTAS 2 and 3. Even after that, there are a lot of delays in the ED. So the main waiting delays in the ED are in between the triage and the initial assessment, that is the waiting time. And also after the initial assessment to the, like when the treatment is going on, the time of treatment is quite long sometimes. And also there is a long delay in discharge, stay after disposition. So from the data set, we have seen that these different times, like waiting times, time of treatment, total LOS sometimes can go up to like 80 hours. And also that increases the stay, like this number is mainly increased by the stay after disposition. Taking all this into account, we have done a few literature studies to understand the impact of overcrowding in the emergency department. So it's a very complex system, but there are studies that has been done that have looked into these two indexes, overcrowding scale and how efficiently the emergency department is working. Although they found there is a weak positive correlation between overcrowding and the emergency department working index. Some other literature studies have shown that there are modeling approaches that has been done for optimizing the ED efficiency. And also there has been studies done for managing resources to reduce patient waiting time. Those are mainly focused on medical staff and beds in the hospital. But we all know that hospital staff are already overworked. There was another study that showed a 5-year case study of a real-time dashboard, which needed multi-center studies to be conducted in order to like get the in order to do more quality assessment of that. But these kind of dashboards with complex information can be overwhelming for the hospital staff. So we thought of an idea that can make it easy for them. So for patients in the hospital ED and for the staff, the main questions are like who is needed and where is needed. So for that, we thought of a simple device that can initialize with these 3 things like are you a doctor or nurse or a staff? So you initialize the device with these 3 buttons, and then it has a simple digital display that has these 3 buttons again, but now they will work as input. So the first one is who do you want to call? That's input 1. And the second one is 1, 2, 3, 4, 5. That's based on your emergency level. So these 2 are your inputs when you want to call someone to this room where you are. And these are the notifications that you are receiving that tells you where you have to go next. And the color bars are representing the emergency level where you have to go. So the advantage of this simple device can be that the doctors, nurses, and staff, they do not need to check the database or complex dashboard for to know where they have to go for the next patient, or they don't have to like find each other in the building. So for example, in this one, now number of calls received on this is 5. So based on that, I'm going to explain how this works. So who is getting the notification? So when the device is initialized, it will have an ID so if you are a doctor, it will have a doctor ID. So suppose doctor ID 1 has received 5 calls and others have received 4, 2, 3 calls. It can sort the numbers, and the next notification will go to the ID who has received the least number of calls yet, to reduce the burden on someone who has already received 5 calls. So the same thing can work for the nurses and the staff. So that's how the notification works. And also we have to identify how the room ID is detected. So this device can contain a real-time location tracker that can track the location inside the hospital. So if this is a blueprint of the hospital floor, the device, when the device is installed in the system, it will already know where is which room. So this information will already be there in the database. And this screen is not needed, like the doctors and nurses do not need to see the screen. This will be monitored by our IT people. So suppose, for example, in room 18, you see there is a doctor, and in room 4, there is a nurse. So if the nurse has to call the doctor in room 4, they can just simply use the device and call the doctor in room 4, and the doctor will get a notification to go to that room next based on the emergency level. So what are the pros and cons? So this device is easy to carry like a watch, and the notifications are very easy to follow. So it will make the communication faster and less hassle. and it has a potential to reduce the treatment time and waiting time. The cons can be the real-time tracking device might be a bit costly, and it might need some amount of human monitoring, and this system cannot track the resources in the hospital. So keeping that in mind, how can we boost ED efficiency even more? So for that, we thought of a simple screen, a digital screen that can be, so ED beds and rooms can be equipped with this simple digital screen for manual entry of the status. So it can have 3 status, either it's occupied or empty or cleaning needed. So based on all these manual entries in different parts of the ED and the whole hospital, we have thought of a draft of a status dashboard, which is very simple to read. Like for ED beds in floor 1 and 2, you know which one is occupied and which one is empty. Same for the other places. And it can also work for other rooms where you are doing some tests or radiology. So with these 2 devices, the future direction is to test like how efficiently they're working. So we can compare patient length of stay before and after installing these devices. So for that, we might need few weeks of hospital data after they are installed. And then we need to quantify the following parameters before and after this device was in use. So the same parameters I have shown before, like waiting time, time of treatment, and all this. And then we can also acquire feedback from the hospital staff, like how happy they are using this device, because they are the ones who is going to handle this. So it should not make another level of complexity for them to use. So our expected outcome would be like to reduce all these times after using this device. So this is what we expect ideally, but yeah, so the limitations we have till now is that for this quality assessment, we need like few case studies, and we do not have a model to quantify with these devices. And the data set that we had, that does not provide info about internal ED delays, so we could not have a before-after timing. But the good thing is this device can make the communication in ED much faster and easier. It can reduce the hassle for everyone. It can reduce internal delays and reduce treatment time and waiting time and patient alerts. So with that, I would like to thank MedTech, McGill, and HackMedTech for giving us this opportunity to participate in this contest. I'm happy to take any questions. Thank you.
Fantastic. Thank you so much. Questions from the judges, please.
So I have 2 questions. Just want to start with the first one. Can you remind me the assumptions or the workflow of how a patient goes to a room and who decides to call the physician, for example? Sorry, I missed that.
So here, you mean this slide?
Like, how does the patient decide, or who decides the patient goes to room 15?
I see. Oh, maybe you are referring to this one. So this is for like the overall status of the hospital. So if you are a doctor or a nurse and you are ready to take a patient to a room, you need to know which one is empty and which one is not. So then from this dashboard, it can be easy to see like where I should go now.
And does the system help deciding which patient should be seen next?
Yeah, so that is here. So based on like if you are a nurse who is already in a room and you know this is very emergency, so then with this device they can call a doctor pressing on D and 1. So that means they need a doctor with then they urgently need a doctor in this room.
Sorry, maybe I wasn't being clear. How do you decide patient X goes to a given room? Like, how do you make that decision? Is that currently done? Your system doesn't address that part, right? Like, it addresses the other items, but the first decision to say, okay, I want patient named X go to room 15. Does your system help in that decision process?
Okay, no, this device helps doctors, nurses, and staff. But what you are asking is that is taken care here. Like this dashboard will be like at the front, and there, whoever the staff or the nurse who is taking the patient, they can see this dashboard and they
Which
can
room
decide
is?
where to go. Yeah,
Okay,
which room
sounds
is
good.
empty. Yeah.
My second question was, actually, you know what? I forgot. I'm going to come back to that question. I'll let somebody else ask theirs.
Okay.
Other questions from the other judges? Okay, if not, then Anthony, it's back to you. Okay, otherwise, if there's no more questions.
Sorry. Oh, yeah. Sorry, I was
go
muted.
ahead.
A quick question was, why a device, not an app on a phone? Because everybody has a phone and phone can be used for tracking. Just a curiosity, why did you thought of a device, not a phone?
I thought of a device like a watch because I feel like carrying a watch is much easier than carrying a phone. And while working, a phone can be like very distracting. Like the phone has many other things, so it can be a bit distracting while working. So just a simple device with this interface, like a watch, you wear it and you know like where to go, something like that.
Okay, but there's a lot more rooms than 5, right?
A lot more rooms.
Yeah, there could be 70 rooms in a department.
Yeah. So we can add like this can be much complex. This is just a simple
Okay.
example, like how it works. Yeah.
Thank you for your ideas. Thank you.
Excellent. Any other questions from the judges? Okay, great. So we will now take a quick 10-minute break. We'll see everyone back in 10 minutes.
Yeah, listening.
Okay, everyone, we'll start back up in a minute. Our next team is emergency lists. Emergency lists, are you there and ready to present?
Yes, we are. Let me just share the screen.
Okay, very good.
Shall we start now?
Maybe let's give it another 30 seconds for everyone to get settled back in.
Hope the judges are all here, right?
Yes. I think the judges are back with us.
Yeah, I'm here.
Yeah, likewise.
Okay. All right, emergency list, please take it away.
Thank you. Hello, everyone. Today, we will present our emergency list solution, which is an app for real-time prediction of ED waiting time. We are Arsni, Ahmed, Nico, and Faiza. First thing, the emergency department is a very complex place with a lot of influx and outflux of patients. The general process starts with patients arriving by ambulance or on their own. After that, they triage to determine their acuity level. And based on the triage level, they wait to see a physician. At this stage, they will start to get anxious if they are waiting for so long without clear estimate about when someone will see them. And they might start disturbing the physicians, asking them when they're going to be seen. Finally, when a physician sees the patient and evaluate them, the decision is made to either discharge or admit to the hospital or require further testing to evaluate the state. So if we have a real-time prediction of the ED waiting time, this will help both patients and clinicians. It will help patients to decide which hospital to go to based on the different waiting time, and also be less anxious when they arrive to the hospital because they're gonna know an estimate on when they're gonna be seen by a clinician. It will also help the clinician to adjust the workflow and operations and minimize the time spent on answering patients' queries about their waiting time.
Okay. Hi, from here on, I'll be using numbers that I took from the data that was provided to us about the ED visit data at William Osler Health. So the first thing to note is that the amount of time a medical worker spends on a patient has a clear correlation to their triage level. As you can see, number 1 is much higher than number 5. And the second thing to note is that the emergency department's patients are generally in level 2 and 3. Somewhat counterintuitively, the patients assigned to that triage level are also the ones that have the biggest spread in wait time. At level 2, some people can wait more than 20 hours, while some people on level 5 never wait more than 6 hours. So here we have some graph representing data taken from a random assortment of 5 days. The graphs on the top represent the amount of patients an emergency department receives at a particular hour. And the graph at the bottom represents the average wait time that people experience in these hours. So it is somewhat noticeable that early in the morning, when there's not a lot of patients coming in, the waiting time is a lot less. What these numbers seems to support is the commonly known common sense conclusion is that unless you're about to die in the next hour, you're probably not getting a prompt medical attention if the emergency department doctors are busy taking care of other people. So what should people do then? As we saw in our first graph, we can't really ask doctors to decrease the amount of time they spend on patient because the vast majority of their patients are at urgent or emergency triage level. We also can't increase the amount of doctors as this power is reserved to the administration or the government. What our team decided is what people can do is not overwhelm an emergency department. There are websites out there on the web that do real-time tracking of hospitals. They can give you the amount of free beds, the occupation percentage. Some can even give you the amount of malpractice suits a hospital received in recent times. The data is out there and is freely available. Now, about how to take advantage of this data, I will leave to my colleagues to explain.
Okay, how does this work? As is well known, accurately predicting waiting time at walk-in hospital facility can significantly enhance both patient satisfaction and hospital efficiency by providing a better management of patient flows. So in this slide, I want to talk about how our platform would be help patient to check emergency room wait time around choosing a day and level of the problem. To begin, we ask the patient to choose the day on which day would you like to check the waiting time at the emergency department of the hospital, and we verify the accuracy of the selected time and then using the work clock. And then we ask the patient to discuss their medical issue, and an automatic triage system based on AI can be utilized to predict the patient medical condition or problem to determine the severity of the patient's condition and assign them a priority level for treatment. This can help to reduce wait time, improve the patient outcome, and optimize the use of the hospital resources. And simultaneously, we use the Google API to read the patient locations, means that while performing some other tasks or action, the system is also assessing the Google API to read the patient location data. And the Google API can provide location data based on the various signals such as GPS, Wi-Fi, and etc. cell towers. And so based on the patient level of the medical emergency, we identify the nearest hospital that can provide the fastest assistance based on the machine learning data analysis. Overall, using machine learning to predict waiting time in the ER can help improve patient care and outcome, optimize hospital resources, and ultimately saves lives. And once the waiting time has been predicted using machine learning, the next step would be to show this information to the patients and allow them to make information decision about where to seek treatment. And our way is to display the predict waiting time on the mobile app that a patient can access. And finally, send this information to the emergency room. This program should suggest a series of steps that should be taken to ensure that the patient can secure a place in the emergency department as quickly as possible.
So here's the overview of our application. First, it displays a map with nearby hospitals and emergency departments. Then the user can select a hospital, and then our predictive model will display the predicted waiting time based on the historical data and the current data. And also it collects user feedback and constantly collect other data to improve its prediction and make adjustments to the system. Here are some important factors that will be given to the model as input. The first one is chief complaint, and then it's triage category and time of the day, and historical waiting times. Some emergency departments are consistently busy at certain times of the day. So they're likely to be busy again in the future in that times. And then it's patient acuity, So some patients with more serious conditions, they require more resources and attention, leading to longer waiting times for other patients. And then there are obviously ED capacity and staffing levels, and also patient demographics such as age and insurance status. So for example, uninsured patient may take longer, and pediatric patients may take less.
Okay, so how exactly could we test the efficiency of our application? First, we should select a testing zone containing a few emergency departments in proximity. We then analyze their visiting data as it is at the time of the selection, and we use this data to train our application. Now, because we're not sure about all the ethical consideration involved in testing an app on which real life would depend on, we'll give a rough simulation on how to test this app in condition as close to as real life as possible without going into the consideration on how much it will cost. First, we consider each hospital as a sort of a closed system with unchanging amount of doctors and an unchanging amount of average time spent on a specific triage level patient. Then, over the next half a year, we will spend tracking each patient going in and out of that selected zone, and we will need their address from which they started and their triage level. After we get this data set, we can now begin testing. We create a simulation where each of these patients acted as if they had access to our app and made their decision accordingly. This will generate a new synthetic data set upon which we can repeat our analyses. We then compare the results from the synthetic data set and the real-life results, and we will be checking if the spread of patients across the emergency department and their average waiting times. If there is a noticeable improvement, then we can test it in real life with the same steps and wait for user feedback to help us improve. And well, that's it for our presentation, and thank you for your attention.
Perfect. Thank you so much. Any questions from the judges?
Yeah, Anthony here. Question regarding how do you collect the information from all the patients that are older, that don't want to use app, that present themselves to the ED? How does their presence or their decision making impact your app, or does it not?
Well, I suppose we haven't really taken that into account, but what could happen is that that could be part of the user feedback, because when we're gonna test it, we're gonna test it on data that the patient does not provide except their address. And so if there's gonna be a noticeable effect for aged people who actually aren't going to use the data, then I think it should be pretty noticeable. So we could suppose during the testing we can randomly see some patients depending on their age. We would be able to see if their effect in general affect the usage of the app, its effect.
Also, like if they have relatives that can use technology, they can help. And if they are present in long-term care, you're gonna have like nurses and doctors to, or like nurses to help them with that if they need.
Yes, that could be also possible as a possible adjustment. So if there's relatives or if there's nurses around, like if we take an old person, if he's isolated and he does not he is not using this phone, then this application, then we can't really test it. But we can sort of simulate his effects. We could we just take his usual trajectory as some kind of as a hard-coded part of our simulation, so he will not be adjusted depending on his use of app or not.
Thank you.
Other questions from the judges?
I had a question about the prediction. So the patient gets to select their complaint. And I think that's the same question I brought earlier. So somebody could game the system by wanting to go faster and making a complaint that is higher, importance. When the system calculates the wait time, does it account for the people who haven't been admitted yet? So for example, if we have 10 people at the same time who say, I have a heart attack or a knife in my back, would that change the predicted wait time, or is the wait time only calculated on people who have already been admitted?
Oh, it should be depending on people who are already admitted. Like if the hospital admits these people, like if when there is an interaction between the app and the hospital, and they say this patient is admitted, then and only then it should affect this affect the response of the app. But if people lie when they send their information, then yes, it is a very possible problem. But like I don't think there is a possible solution except when if the doctors see that nobody came in at the expected time. There's not well, we could as a possible security measure make patients input their medical insurance card number and their ID, but that's gonna have some ethical considerations in it. We're not sure how allowed it is. It's going to be heavily dependent on ethics.
Yeah. Thank you.
Okay, very good. Well, thank you so much. Our next team is Caduceus. So can our next team please present?
Hello. Hello. I can share the screen here. Perfect. Perfect. And we're good to go?
Looks good.
Okay. So good afternoon, everyone. We are Team Caduceus, and we are very excited to share our pitch with you all. Next slide, please. I'm not sure if the slide's changing, but I cannot see it.
No, it hasn't changed.
Okay, on my end, it has changed. I'm gonna launch the I'm gonna launch it from the PDF here. Okay, perfect. Okay. Okay, that's perfect.
Awesome.
Yeah, so next slide, please. So yeah, just a brief introduction. My name's Braden, and we'll soon hear from Dante, Ali, and Robert. Unfortunately, Anika could not make it today, but she's here in spirit. And we're all students from Dalhousie, hence the black and gold color scheme. So without further ado, let's get into our pitch. So the following is the structure for our presentation. We will start by explaining our interpretation of the problem definition and how we came to identify areas to optimize in the emergency department. Then pitch our solution based on one or two of the identified areas, followed by our solution testing plan, and we'll conclude by wrapping everything up before a questions period. So I will hand it over to Ali to present the problem definition.
So the challenge presented in this hackathon was to improve performance of ED flow with minimal infrastructure investment and no patient harm. This was to be done by proposing a technology or a solution to optimize a critical steps for the system as a whole, specifically the metrics to optimize for patient throughput and ED wait time. And so we'll now go over a basic overview of the emergency department workflow And the workflow we're showing here was based on Dr. Felfer and Dr. Roberts' presentations. So first step is arrival at the emergency department. The flow through here is affected by arrival mode, the seasons, and the time of day. Patients then go through pre-triage before moving into triage. So flow here is affected by an individual's pathology and acuity, the number of triage nurses, and other staff. For our purposes, we're following the CTAS emergency system of 5 levels of acuity, level 1 resuscitation, down to level 5 non-urgent. So patients are then registered and assigned to one of 3 locations, the resus bay, stretcher, or ambulatory zone. They then undergo a couple rounds of treatment and MD assessment, where the flow is impacted by the number of physicians, allied health personnel, number of beds available, and the number of patients waiting for lab reports. A patient's stay in the ED ends with discharge or admission. And so we use this workflow as well as personal research and conversations with various healthcare professionals in order to identify potential targets, which we've indicated in red, before narrowing down our scope to the points in blue. And so we've identified the assignment to location, awaiting tests, and time to a decision of discharge or admission as the critical limiting steps for ED workflow.
So here's our solution pitch. Our proposed solution involves the implementation of an interactive 3D centralized hub of information. What this would mean for physicians is that they would have instant access to high impact information, such as electronic medical records, bed location, CTAS score, requested tests, and status of results. For nurses, an additional predictive AI tool to assist the decision-making process associated with admission and discharge to or from the emergency department.
So how can this program be implemented? In terms of data processing, we'll leverage machine learning. So there's a model led by Dr. Alan Cameron in Glasgow, UK, which predicts with up to 95% accuracy the likelihood of admission based on medical history and triage information. So for example, if we input a patient's age, long-term conditions, CTAS score, etc., the algorithm would spit out the probability of their admission. This, as a feature of the app, would provide support for charge nurses or bed managers, and as well give physicians a better idea on how to prioritize the resources to maximize discharge. One could implement this predictive model using C or Python or whatever language you prefer to implement the rest of your program in. The results being an interactive real-time bed assignment assistant that prioritizes throughput. And the interface, which Robert will touch on next, can be implemented using one of many popular 3D app development environments, such as Unity 3D. Unity is well priced with a focus on expediting 3D app dev projects. So it would be straightforward and lightweight to intuitively display data relevant to this app. All that to say, implementation is feasible and won't strain existing infrastructure. Yeah, so over to you, Robert.
Thanks, Brendan. Okay, so I'll now go over the proposed user interface. This will be an app running on an iPad or a tablet where the user will be able to interact with it on the go. So once a doctor or nurse logs in with their credentials, they'll be brought to the home page, as you see here. This is a high-level overview of the entire emergency department. We model it like a POS, a restaurant POS system, so the user can see important information at a glance, such as like the capacity, as you see there. On this page, patients can be added or removed. Everything can be clicked on, and we'll zoom into that area. So right here, we'll click on the 5 and 4 level CTAS room, and it'll bring us to the room level. So in the room level, the user gets a clear picture of what beds are occupied, how many beds are occupied, and what patients are seeking attention at the moment. The user can zoom, rotate, and pan around this 3D space using intuitive hand movements on their screen. And like before, we can click on a bed to see information about that bed. So in the bed level, it's just a further breakdown to view each bed. This level shows the patient chart and includes the patient name, CTAS level, demographic, encounters, medications, allergies, and medical history. Clicking on each of the colored bubbles will tell you more information about it. And the user also gets to see very clearly why the patient is in that day and any notes from any previous doctors or nurses.
So this solution is important because of its potential for positive effect on throughput. It provides a visual solution which puts high impact information at the fingertips of those who need it. This tool would also help facilitate the work of a bed manager or charge nurse, as Braden mentioned. And additionally, this solution requires minimal infrastructure change as it acts primarily as a user-friendly interface to existing technology that is being implemented, such as electronic medical record and the push for digitalization. This solution would also eliminate potential information overload by putting this high impact information first and allowing access to additional patient notes and information when needed. Now, Ali will share a testing plan with you.
So in order to implement our software, we are presenting a trial length of 1 year. So this is to account for temporal variations indicated by the Kai-Hai-Knackers dataset that shows flux into an ED varies over the course of the year. And we propose to introduce this at a smaller hospital, such as Truro, Nova Scotia. So this serves a medium-sized population, and dire ailments are sent to Halifax, making this a low-risk testing site that still represents a typical emergency department. And just of note is that a similar software has been implemented in a city in England, and that city had a larger population than Truro, so our target testing site seems reasonable for minimal risk. So the testing metrics that we will measure would be to compare patient influx to throughput ratio before and after the implementation of our app, as well as looking at the physician and nurse ratings and comparing inter-rater reliability using Cohen's kappa analysis. Future updates to the app could include modifications reflecting feedback of the nurses and physicians who use the app during testing. It would also be an opportunity to include nice-to-haves as well as more complex features that may require more resources.
And this concludes our presentation. We'd like to thank the various doctors and mentors who engaged with us over the past few weeks, because most of our research was done by meeting with these people. So it's really good to have insight on our proposal from them. We'd also like to thank the MedTech team for hosting this competition. We all learned a lot. And here we have our sources, our image credits, and questions.
Excellent. Thank you so much. Questions from the judges, please.
Yes, hi. Two questions. One of them is, why do you think 3D or an interface like Unity is necessary? It just seems like it adds a layer of complexity that you could get with basic graphic, like those systems you have in restaurants where the graphics are very symbolic. Like, do you think having 3D moving around would help somehow?
So I can touch on this. Feel free to add my teammates. So I had one conversation with a doctor who I presented this idea, and he did mention that they do have a 2D system where they can see the patients, but he thought that it would be a good idea to have the 3D model just because it would help him visualize where his patients are. And it was just, to him, he thought it would make it a little more user-friendly just to see where everybody is in the space.
Other question is at the beginning of the solution presentation, you talked about an algorithm, or there was a study where there's some model that can predict the rate of admission based on known data from the patient. I was curious, how much does that improve what the gut feel of a nurse or an ER doc is? Was there data on that?
There's no data on that, and that's another thing that's definitely important to consider. But I do think if, let's say, a charge nurse is maybe slammed with decisions, this would supplement their gut decision making. So it'd just be like a nice to have. Obviously, if they choose to, they can make the decision based on their gut instinct. But if they think that they might need some support in making this decision, the predictive algorithm could help them with that.
Okay, thank you.
Thank you.
Any other questions from the judges?
Yeah, I was curious, just you mentioned a bunch of things that you would be adding in your 3D model to what existing EMRs sort of provide or trackers provide, what do you think would have the biggest, like what would you want to test to have the biggest or expect to have the biggest impact on patient flow?
So I can start with that again. So again, from conversation, one of the reasons we put in the predictive model that Braden just talked about was that one of the doctors we were talking to said that in his opinion, one of the biggest time consumers was obviously the decision to admit or discharge. And so having that predictive model available to the charge nurses, he thought would be very useful in improving the flow. And so I think that would be one of the one of the major, most important things of this app would be that predictive model.
Perfect. Well, if there's no other questions, thank you so much. And we'll move on to our next group, which is group 12. So please go ahead. Group 12, are you here and ready to present?
Yes, just sharing my screen.
Okay, perfect.
Can everybody see that clearly?
Looks great.
Are we okay to begin?
Yes, go ahead.
All right, so thank you for having us. And today we're going to be talking about our solution, which is a digitized health record database. Great. Let's see if it works. Sorry.
Okay, so I'm going to explain a little bit about the emergency department flow. So like the step one is the patient enters and talks to the nurse registers the patient, and then the nurse is able to gather, the online medical history of the patient. And then after checking the online records, the nurse decides to call the pharmacy or doctor's office for more information. The second step is basically there's a nurse or a physician who performs more deeper diagnosis, and this includes radiology or the lab. So they basically perform examinations and tests to diagnose the patient further. And during this process, they also make sure to check the medical records, the online medical records, but then decide to call pharmacies or doctor's office for the medical information. And then essentially the last step of this part is before the doctor makes a final diagnosis or a treatment plan, he may decide to call a pharmacy or doctor's office for more additional information. And the process can basically end with either the patient receiving their treatment, undergoing surgery, or being referred to a specialist.
So what are the primary issues with the emergency department? A lot of them can be argued to be poor financial planning, legal constraints, and lack of attention to the workforce, and so on. But ultimately, the biggest issue is people, or lack thereof. And of course, we can't create more people, so we are aiming to help the people that already exist. And based on the people we've spoken to, the main problem we found has been within communication. So as we know, many patients, especially in older demographics, have very complex medical histories and many prescriptions. This can be difficult to keep track of for the patient. Should they have to visit a hospital, that is a lot of information that has to be collected, which adds up to large delays in the waiting rooms. And with today's technology, we really have to ask, why is this still happening? So first we ask what is already in place to address this, and that would be the eHealth software. It's designed to centralize electronic medical records, contains lab results, imaging testing, medications, and is accessible through an online portal, which sounds fantastic in theory, but there's several problems with this. So we spoke to a pharmacist, Michael Muzo, who told us that he receives phone calls from the hospital on a daily basis for patient record requests. This seems strange because eHealth was developed primarily to solve these problems. So why is he still getting these phone calls? This is because eHealth is designed to be a centralized record system, but it doesn't solve this problem. And here's why. So first off, the online portal is quite a hassle and inconvenient to use for healthcare workers. And here's a quote from Dr. Lucas at the Innovation Medical Clinic, who says that it's no secret that many physicians are unhappy with their electronic health records. They say they spend too much time keying in data and too little time making eye contact with patients. They say their electronic records are clunky, poorly designed, hard to navigate, and cluttered with useless detail, which psychology have cut and pasted to meet documentation requirements. Meanwhile, the data they really need are buried almost beyond retrieval. And we also spoke to Lauren Anderson, who is a registered practical nurse at William Wolter Hospital, who reflected a similar sentiment, claiming that they prefer to take phone calls for patients with several prescriptions, which could lead up to 10 minutes per patient over using the online portal. Now, this leads to our next issue, which is that eHealth has a very all or nothing approach. Facilities often use their own electronic health records, which still only store things at a local level, which doesn't advance the ease of passing information around, as people still need to call around to get the information. And eHealth relies on the hypothetical reality where everyone uses it. But a vast majority of POS systems in hospitals are not compatible with eHealth, which leads to the reliance on the janky online portals.
Yeah.
And here's a quote from the eHealth connectivity strategy, which shows that, where they claim that for the foreseeable future, it is necessary to rely upon these online web portals, which means that they don't have a way to directly address the primary issue here. And finally, difficulty adapting to change.
But how, like, if ChatGPT can replace you on top, what should you do? Then I will cry. Is that usual?
Wait, pardon?
I think that was in the background.
Oh, okay, sorry. Yeah, so difficulty adapting to change. In a system such as healthcare, implementing major changes can be difficult as it takes time for staff to adapt, especially if said changes cost more time to and replace old headaches with new ones. And in a system such as healthcare, where every second counts, it's better to have old headaches that you know how to deal with rather than new ones. And also, migration is quite a lengthy process. There's a lot of data that only still exists at the local level. So for many practitioners, the hassle of migration is just not worth it.
So I want to talk about our solution. The idea of eHealth is fantastic in theory. However, due to all the practical issues, we think we can make it simpler and more widespread. Our solution aims at making the user interface of these EHR applications simpler and easier to view, meaning removing the need for online portals while maintaining or even exceeding the standard for privacy and security. Before explaining each component, let's see what this process looks like visually. So you have a patient who walks into a hospital that they have never been to with their health card. When it's their turn, they're called into triage where the nurse is. Their card is swiped. Software instantly pulls up the medical record before the nurse even touches the mouse. The assessment made from speaking with the patient and viewed medical history is added to the record by the nurse. The record is a live edit, meaning if the nurse makes a modification in triage, when the patient ends up in, let's say, the X-ray room, the doctor in there can see those changes made. Once a patient has swiped their health card on a network, let's say like a hospital, it's no longer needed for doctors to swipe that health card again to view the record, since the computers they are using will already be authenticated. So let me explain this. The first component is the database, and this is the simplest component. It's existing technology, and it'll hold every piece of medical information of every Canadian. The primary difference between eHealth's central repository and our database is how it communicates with our software, which I'll get into in the software section. Centralizing, sorry, go ahead.
Yeah. So how does centralizing information help? Just to step back and go over things a little bit. So first off, we have faster access to patient information, which we went over. This means that staff can have their hands freed more easily to attend to more patients. There's less reliance on a patient's memory. And also it allows for more effective analysis of data and trends. This is an invaluable source for things such as epidemiology, which allows us to be more proactive during epidemic cases such as the COVID-19 pandemic, where countries such as Denmark, who have very thorough national registries, were able to make a lot more well-informed decision and lift their restrictions way earlier. And also having one software will also standardize licensing costs, as every practice will be using the same platform.
So the second component is the health card. And originally, we wanted to put the records on some sort of physical device like a health card. But looking at the back of this card, it contains a magnetic stripe, which unfortunately does not have enough space to store this kind of information. So we thought, what if we can turn it into a key? Our proposal is to magnetically modify the 3 stripes on the back of your health card and convert it into a uniquely encoded digital key. The plus side of already having magnetic cards is that they are modifiable. The data on them can be changed with relatively simple and cheap equipment. Given that our solution involves swiping a patient's health card, a basic magstripe reader/writer in the triage offices will achieve this. This allows Canadians to walk into any medical facility in Canada and swipe their card, granting physicians access to your medical history on our database. Think of your health card as a key fob and your hospital as your apartment building. It would be silly if the concierge had to open his computer and log into some clunky portal to open the door for you. You simply tap and enter because ownership of the fob is your authentication, and we want to transfer this principle to the emergency department. And the third and final component of our solution is the software application that controls the health records. As mentioned, physicians just aren't satisfied with the current software surrounding electronic health records. We believe that the technological advances made towards accessing EHRs is counterproductive. Physicians want everything black and white, plain and simple, and we intend to make the user interface nearly as simple as an Excel sheet. Our software effectively eliminates the need for any sort of complicated migration process from existing point-of-sale systems to new software. So how does it work? Well, there's 2 components. One is the dual-factor authenticator, and the second is a data miner. In Canada, privacy is not something taken lightly when it comes to medical information. Our goal was to develop software that did not require any sort of login or entry process when querying medical data. However, this does pose a significant privacy risk. To overcome this, our solution implements a dual-factor authentication process, the health card on the client's end and the software on the user end. Licensing for our software is only granted to licensed medical practices. By doing this, the ownership of the software itself is the authentication on the user end. In terms of security from external threats, like hacking, we want to adapt the same blockchain technology used for cryptocurrency. Every local network that owns and operates our software is a node in the chain. This way, calls to query records are verified by every computer on our network. Despite the stigma and news stories surrounding the uncertainty in crypto, the number of security breaches is tiny compared to the platform's use, as you can see by the graph. The hashing algorithm used to encrypt transactions is still nearly impossible to reverse, and blockchain technology shows promising results for the future of electronic security. The second function of our software is to autonomously integrate local point-of-sale systems with our database. To do this, we intend to use artificial intelligence to essentially enter, search, and collect local electronic records, bringing them back to our database. eHealth's EHR contribution architecture is behind in development, and there exists only a definite and finite set of point-of-sale applications compatible with autonomous migration. Our model will be capable of discovering and navigating even an EHR system released yesterday by using navigational algorithms to work through software, as well as language models to accurately extract records and notes from a patient's file. The data is then organized and stored in our central database for use anywhere in the world.
The thing of the software needs to be divided into 2 parts. The first one is testing the software by itself, and then the software needs to be tested in a simulated environment. For the first part, the steps are identify the requirements. This involves setting specific functionalities of the software that need to be tested. Develop test scenarios. These scenarios should be designed to test the functionality and usability of the software and to identify any potential issues or bugs. Then we have to determine metrics. These metrics could include response time, reliability, accuracy, and other key performance indicators. We need to conduct the tests and then collect data, analyze the results. For the second part in the simulated environment, next slide, please. For the simulated test, we have like different steps. First, we have to identify the requirements. So as before, this involves setting specific functionalities for the simulation that needs to be tested. Then we need to develop test scenarios to be executed during the test, determine metrics. In the case of the emergency department, the recommended main metric would be the throughput rate. Select participants. So these participants would include healthcare professionals, IT staff, and end users. Then we have to conduct the testing. So as before, we need to conduct the testings that have been designed, and then collect data, analyze results. Collect data, analyze the results of multiple simulation-based settings. This will help to identify any issues that were encountered during the testing process and to determine whether the software meets the requirements and needs to be and the needs of the healthcare setting.
Then the last part is to adjust to errors and bugs. So we have to, if we need to make adjustments, if there are any issues or bugs that were like identified, they need to be adjusted and corrected, implement the software. So once the testing process is completed and any necessary adjustments have been made, the software can be implemented in a healthcare setting. And then we need to provide training and support. It is really important to provide training and support to healthcare staff to ensure that they're comfortable using the new softwares. This can help maximize the benefits of the software and minimize the potential of errors and issues.
And finally, the implementation process. So once the software is fully completed, we'll actually have to implement it into our healthcare system, which can't be done all at once.
Sorry, could you unmute, please? And just running a bit over time, so just get wrap
Oh
it
yeah,
up.
we're just wrapping up. Yeah, so pretty much it would start at volunteering municipalities, since we started a larger scale, where we would observe efficacy and issues. So efficacy being, is it improving throughput? Why or why not? We would gather feedback from healthcare professionals and rework the system accordingly, as they would have the best idea of what's not working, and it would allow us to better gauge if it's ready for larger scale operation. And finally, we would want to increase it to a provincial level, as the bigger the database, the better it works.
Excellent. Thank you so much. Any questions from the judges, please?
Yeah, hey, it's Prashant. Great presentation. Thank you for taking a bit of a different take here. I'm just trying to understand the connection what's your hypothesis as to fixing that sort of the larger electronic health record problem will have a direct effect on ED flow. I'm just curious if you could just expand on your hypothesis why this larger problem solving it will improve ED flow.
I can answer that. Well, we talked a lot about pharmacies and other clinics, which I know is aside from the issue, but the thing is, healthcare is such an interconnected system. Like everything works in unison, because people don't just get medical attention at a hospital; they get it at pharmacies and doctors' clinics. So the hypothesis is, we want all of the information to be held in the same place, as opposed to kind of how it is now, where eHealth only accesses some information and some clinics use their own software. It's kind of divided, and we want to bring unity essentially. And we think that in the hospital, when it comes to assessing patients and filling in data, we think it'll be beneficial to have that all in the same place essentially.
Okay, any other questions from the judges? All right, very good. So thank you so much. We'll now move on to our next team, which is Team Blue. Please go ahead.
Hi, I'm just going to share my screen here and then we can get started. Okay, I hope I'm sharing the right screen.
Perfect.
Okay, all right. Well, good afternoon, everyone. We are Team Blue, also Team 17, and welcome to our presentation on efficient emergency care for Ontario, leveraging artificial intelligence and machine learning to enhance patient outflow. Emergency care in Ontario is facing critical challenges due to limited staff and resources, which results in long waiting times for patients seeking care. Our emergency departments are often overcrowded and staff are overworked. This problem not only causes a great deal of stress and frustration for patients, but also leads to poor decision-making by them, which can have serious consequences. According to recent data, the average wait time in emergency departments in Ontario is over 7 hours, with patient triaging alone taking up to 3 hours. This creates a bottleneck in the patient flow that slows down the entire emergency care process. We need to find ways to streamline the patient flow so that people can receive the care they need in a timely and efficient manner. While adding more staff, beds, or even hospitals may seem like straightforward solutions to challenges, brute force solutions are not always viable. Budget constraints, labor shortages, and the extensive training required for emergency care professionals limit the feasibility of hiring more staff. Similarly, increasing the number of beds or hospitals requires significant capital investments, which may not be feasible. Fortunately, advances in artificial intelligence and machine learning present a potential solution to this problem. By leveraging AI and ML, we can improve patient triaging, optimize resource allocation, and ultimately enhance patient flow.
Hello. So I'll be talking about the solution. So our solution has two parts to it. The first part is mapping you to the best possible hospital based on your needs. After going through the self-triaging process, we plan on finding you the optimal hospital for you. You may ask, how do we plan on finding you that? So we decided that we're going to have a collection of hospitals in our directory, and we will be communicating with them in real time and getting live updates on their current situation. Information that we will be receiving is capacity limits with relation to their department, as well as their proximity. Using these two weights, we will be creating a recommended list ranking hospitals so that we can present this to the patient in their time of need. Should you decide to use one of the hospitals from the ranked list, your information will then be passed on to the hospital, and upon arrival, a nurse will verify your information, and essentially you've now bypassed the triage system. The second part of the solution is continuous monitoring of the patient. Through the app, you will be able to check where you are in the emergency room process. For example, whether you're waiting for testing or waiting for dismissal, as well as the next stage in the process. Additionally, we will be providing you an estimated time to dismissal using a machine learning approach to help mitigate patient stress and anxiety. So the next portion that I'll be talking about is the benefits. So we wanted to tackle our solution through an accessibility approach. In medical emergencies, many do not have the capacity to make critical decisions. Our proposed solution takes the burden off the patient and provides quick and accessible care. So you may ask, why would you use our solution instead of 911? Majority of the times when you call emergency services, it takes you straight to the closest hospital. And sometimes that decision may not be the most optimal because you will still be waiting to be taken care of. Our solution provides quicker care to the patient. The second thing that I want to talk about is resource utilization. As we've mentioned before, the optimal time for triaging a patient is 15 minutes, but often reality is deceiving. We plan on reducing this 15 minutes to 5, saving staff 10 minutes per patient, which leads me to my next point, health outcomes. In the ER, 10 minutes can be a deciding factor in saving one's life. By cutting down time staff spend in triage, it will have a trickle-down effect on other parts of patient care. Staff will have more time to allocate on other areas of concern. And as a result, patients may receive a better care from staff, increasing health outcomes significantly. So lastly, I'd like to talk about our target audience. Based on the data received, we've extrapolated that majority of the patients come to the ER through their own methods, right? And that's who we'll be targeting. Secondly, we've noticed that people who are coming on their own methods do not need immediate attention. So to give like a category, we would be targeting triage levels 3 to 5. And lastly, the demographics age-wise is the ages from 18 to 64, since we know that majority of adults have smartphones, and we decided that this would be the best delivery method for our solution. And just another thing is that we also provide a web application service for the admin side, preventing the need to download additional software and seamless integration into an existing hospital ecosystem.
I will be now discussing about the app design. Now, how does the app work? First, it starts off in the login page. After downloading the app for the first time, it will request the user to log in or create their account using their email and a password. And if they forget the password, they can request to reset their password, and it will be sent to their email address. Next, it will be when creating their account, it will ask for them to upload their health card by picture, and from there it will be saved based on their account. Next, we'll talk about how the user will insert their symptoms. Based on the user will enter their symptoms based on a menu provided on the screen. The app will then ask the user to for their location, and based on their location, it will provide their closest hospital and the respective location. And in this example, there are 4 hospitals near the person. After the user has picked their hospital, the information will be directed to the chosen hospital, and from here, this is where the triage spot will be reserved. Now,
so after careful consideration and analysis, we have come up with a budget of $676,400. This includes a front and back end developer, engineers, a project manager, a server, equipment, and a designer. However, it is also important to consider additional costs such as ongoing maintenance, potential upgrades, legal and regulatory compliance, and any other expense that may arise. Our implementation plan, it will consist of 5 key steps. The first step will be to create a prototype of the system, which we will use to test and refine the technology. Once a prototype is complete, we will move on to the second step, which involves live trials and testing. These trials will help us to identify any potential issues and refine the system even further. The third step of our plan will be a beta launch with 2 hospitals. This will allow us to test the system in a live environment and gather feedback from medical professionals and patients. After the successful beta launch, we will move on to the 4th step of our implementation plan. This will be a phased rollout consisting of 4 phases. Each phase will involve the rollout of the system to a specific regionally grouped set of hospitals. During each phase, we will have a dedicated team to monitor the system's performance and gather feedback from the hospital staff and patients. We will also conduct regular reviews and analysis of the system's data to identify any potential issues and make necessary adjustments. Finally, our 5th and last step will be the Canada-wide rollout of the system. But we will work closely with all hospitals to ensure that the system is implemented efficiently and effectively.
A few limitations to the app is that the AI and the machine learning that the app uses does not replace human expertise, meaning that triage nurses are still required to double check the symptoms recorded on the app. Another limitation is data privacy. As there are confidential and privacy concerns to the app, this app must follow HIPAA regulations and must be protected using a cloud-based storage. And finally, there is funding limitations. The app must be funded by the government using government funds, grants, or crowdsourced funds. And not to mention that the app must not use ads to profit from this. A few considerations is that the staff is to determine the staff needed per hour by predicting the patient input per hour using past patient throughput data. They also need hospital data for number of physicians needed, beds available, and live data for testing wait times. Another consideration would be on weather data, traffic data, and holiday seasons. And another consideration that we'll be trying to implement will be redirecting additional health services, including pharmacies, urgent care centers, walk-in clinics, and dentists. And now there are a few impacts that the app will create, which is the decrease in stress and anxiety due to more information available to the patients, a decrease in burnout in healthcare workers such as physicians and nurses, and reduce unnecessary distribution of resources such as ambulances and 911 call takers. Finally, it will reduce the wait time due to information already provided, and the nurse will either double check the symptoms and record new ones, while also taking vitals such as the pulse oximetry and heart rate.
And that's our end of our presentation. Any questions?
Yeah, if I can go ahead. Can you clarify what you mentioned relating to 911? Like you're replacing them, or instead of calling 911, they use your app?
Yeah, so we're providing like an ancillary service, like an alternative to 911. So we're reducing calls to 911 for like non-emergent patients, as well as like redirecting them to what we determine to be the most optimal hospital.
Okay, maybe just if I can clarify. So you mentioned 911, so often it's patients that need to come by ambulance. But 911 also does, in Quebec especially, they send any first aid services like firefighters or everyone. So there'd be someone on site within 5 to 8 minutes. And that's where they decide, okay, you're non-urgent, you can go on your own or you can stay home, or yes, we'll take you. That's a lot of patients that are very sick. How are you gonna serve that population if they use your app?
We mentioned earlier in our presentation that we were focusing on patients who do not use like the ambulance. Well, like from what we've seen through the data that was sent to us, majority of the cases they came through their own. So we're targeting those patients as well as patients who are like non-emergent.
Okay, I understand. So maybe you're not competing with 911. You're providing a service for those who do not need 911. Because if you're calling 911, that's potentially because you're really sick. So maybe I think that's just part of your pitch that you need to clarify, that you're not a competitor to. You're maybe replacing the help phone lines, like in Quebec it's 811 that answers questions and tells you what to do, but you're not competing with the 911, which brings you there by urgent need. Okay.
Yeah. The
Sounds good.
goal
Thank you, guys.
The goal is to redistribute the patients. We know we have, primary, secondary, and tertiary hospitals, and based on the symptoms that they input into the app, instead of, calling 911 and having them like just deploy an emergency service, and then having the emergency, the people working, the ambulance, the physicians in the ambulance determine whether or not they need emergency care. This would be for the patients who don't need emergency care, and then they could be allocated to hospitals that have low wait times that are more appropriate for the symptoms that they are experiencing. So
And you may have a component that says, please call 911 for this because your problem is too urgent. Yeah. Okay. Awesome. Thanks, guys.
One question about the when you were showing the app, one of the first step is to register and get a code and an email and all of that, and then you show, okay, choose your complaint, for example, a broken bone. I was imagining that any app that requests a registration, an email back, scanning a card or anything like that that's a lot of friction, especially in an emergency environment, unless somebody has already installed the app ahead of time. So would there be a way to make this work without registration, just the app, and then register later?
I think we can eliminate the registration process of like creating an account and then just having them directly upload their health card or like their contact information. So when they are arriving at the hospital, let's say an emergency happens on the way, like the hospital would have their registered this registered patient that's supposed to be arriving at the hospital, and they can contact them if needed.
Yeah, that might help. Thanks.
Okay, very good. Thank you so much. So we'll move on to our next team. One more team before we take another break. So NanoZillas, you're next. Please go ahead.
Hello. Can you hear me?
Yes.
Yep. Awesome. I'll be sharing. Can you see the presentation? Fine.
Perfect.
Awesome. Hello, judges. We're Team 18, and we're here to present to you EDQ, our solution to improve throughput and minimize the length of stay of patients in hospitals' emergency departments. This presentation is presented to you by my teammate, Nikhil, and myself, Tom. As you might know, waiting times in ED can be long, especially when in urgent need of assistance. On average, in Ontario, patients waited an hour and 15 minutes in 2022, and the length of stay is on average between 3 and 21 hours, depending on the urgency. We found that the 3 biggest factors for such long waiting times are the limitation of resources, such as not enough staff or beds. It is also often overcrowded through the year due to seasonal illnesses or accidents. And finally, we found that The systems that we are using today are usually complex and inefficient, which results in longer waiting times. Those waiting times greatly impact patients, as it can delay treatments and increase stress and anxiety, not only for the patients, but also for the staff working at the hospital. And finally, it overall decreases the patient's satisfaction. So patients might not come to the same hospital as often if they're not satisfied with their treatment. So the solutions to these problems will be presented by my teammate. Nikhil.
Hello, can you hear me? Hello?
Yeah.
First of all, the way we are approaching to tackle down this problem is in several stages. First of all, we focus on the patients who do not require immediate medical assistance. At first stage, we make sure that if they do not need emergency assistance, they do not reach hospital. In second stage, we try to eliminate further the risk in the emergency department by, if the patient moves into hospital, we make sure that this patient do not reach us ED. And still, if the patient has to move on to ED, in the third stage, we try to filter out by providing an assistance so that it does not create any burden to the hospital administration. So the first solution is the live chat in our mobile application. So there you can speak with a patient representative who is available 24/7. And based on the series of prompts, you can quickly and accurately determine what is the severity and of the health condition. And based on these answers, the patient will be directed to the nearest hospital or doctor's clinic if possible. And thereby, we make sure that if it is not severe, they are not moving on to the hospital or the emergency department. And the responses can be saved in our mobile app so that if in case they reaches the hospital, these all records can be retrieved. Next slide. In the as a next step, if the patient is moved or the patient has to move to the hospital, in our mobile application, we will be introducing a live dashboard which will be showing all the nearby hospitals and the approximate wait time in each of these emergency departments. We are trying to make this live dashboard by collaborating with emergency department at each of the hospital, and these data will be updated in real time in every 10 to 15 minutes. So in case suddenly if I have to go to hospital, I can just log into my mobile application and see which hospitals A, B, C, or D has the more wait time. So thereby, even if the patient has to go to hospital, we are trying to distribute the patient so that it does not create overcrowding at any emergency department. Also, we also provide historical hospital clinic traffic and also the wait times. Next slide. And as a third step, if the patient reaches or has to reach the emergency department, we are also providing further reservation system where in which if you could select your hospital where you have to go, you can reserve your time slot. Thereby, instead of going and waiting for 5 or 6 hours, you will be given a particular time slot so that you can just be at that hospital and that given time slot. Also, in our application, we have created, we'll be creating a reminder 30 minutes before and also 5 minutes before the appointment. Another provision will be provided for cancellation of your reservation at any time. Also, upon your cancellation, the reservation will be updated for another patient or customer who is in need. So reservations against the cancellation also will be included in our mobile applications. So in this mobile application system, we can choose which hospital you want, and the location and the wait time, all the other stuff will be automatically updated. And based on our conditions, we will be assigned to the queue. Next step. Looking into the ED structure, in the emergency department, we have emergency observation, emergency rescue, and emergency clinic. As I have mentioned in the earlier, for the very serious case or acute cases, all these diversion strategies are not a practical solution. So we are trying to minimize the busy in this emergency department, focusing on the patients who do not really require emergency attention. That's our first and foremost aim. And we are focusing on this emergency observation. We are targeting them, those patients, thereby emergency clinic, to reduce these non-critical patients. And thus, this reduced number will allow nurses to focus more on emergency rescue. Next slide, please. As a testing plan, we are trying to partner with all the emergency department at all the multiple hospitals. Thereby, we will get a real-time data at all the emergency departments in this hospital, and that can be updated in our mobile application in a real-time manner. Furthermore, as soon as a patient downloads this application and enters these details based on a scanner, so once he reaches the hospital, all the data can be transferred to the hospital system. And also we have the provision to get a real-time feedback from the patient. Next slide, please.
So these proposed solutions are only the start of EDQ. We can bring much more to it into the future, such as incorporating data transfer from clinics, using online storage of important data and reports. We can either bring prescription renewal and inventory updates to our application to make the whole process easier for the patients. We believe that our product can have a big impact on reducing waiting times for patients, thus greatly reducing the overall stress on the hospital and helping save lives in a more efficient and effective healthcare system. Thank you for listening to us, and we hope you have a great day. And if you have any questions, we will be accepting any questions.
Fantastic. Thank you. Please, questions from the judges.
So I'm wondering how step one of your process is different from existing telehealth services right now in Canada. And then, sorry, I missed step two as to how that's also, what's net new there.
Nikhil, go for it.
Yeah. In this step, we are trying to focus on how or the ways by which we can reduce the number of patients coming onto the emergency department. So right now, once we had a survey from different nurses and other medical professionals, we find that quite a lot of people come to the emergency department mainly for minor cases. So once we had a talk with them, they had feedback something like this, that if at least this population, if they can be redirected for minor cases like slight fever, maybe cough, maybe a slight or minor medical cases can be redirected, not coming to the emergency department. So what we are trying to do is that we are incorporate this feature into our application, and we will be insisting on the patients to first move on to this method so that these patients do not move on to the emergency departments.
Gotcha, thanks.
Yep.
I had a question related to this is Anthony. How you think patients will react to this app? Like, for example, you mentioned you can provide them a scheduled time in the ED. The moment people know that they can get to that step, they may always get to that step and say, okay, I want to schedule time in the ED because now it's a lot more easier to go to the ED, even if you shouldn't. You've made it easier. And at the same time, the second part of that question is, how good is the prediction within 30 minutes? Like, how good are we currently to be able to predict someone will be seen in the next 30 minutes? We can try to tackle one or both of those questions. Thank
you. Sure. So, first of all, the reservation is not was not given a predetermined time limit. Doesn't mean that he gets a slot in next 30 minutes. We only mean that we will be sending a reminder just 30 minutes ahead of his scheduled appointment time. So once a patient or a user log in into our mobile application, he can see all the hospitals which are nearby his location. Probably that's where the patient should be going on. So if I take my example, I will look into 4 or 5 hospitals which are nearby my current location. So I will be looking at where are the current or the available appointments where they are available. So based on my convenience, I will be selecting the slot. So once my slot is selected and I book my appointment, our application will be sending a reminder 30 minutes before the scheduled time. This is to make sure that the patient who has reserved for this appointment does not miss his schedule. And again, as a backup plan, we have created a reservation against cancellation. So in case he really misses out to visit the hospital, thereby the system gets updated, and instead of that reservation, we will be providing another slot to any other patient who is waiting for these time slots. That's how we plan to operate. Hello?
Oh, yes, sorry. I was going to say, sorry, I was going to comment, I was on mute. I meant to say, if you were to take your presentation, this part, you book an appointment to the ED online and change it to a nearby clinic, you've now improved the throughput problem for the ED. Now, less people will be coming to the ED, people going to the clinic, and in the clinic, it's easier to predict the time. So I think that one change could make this a lot better. Just a suggestion.
Okay,
Thanks for your work.
Yeah, thank you for the suggestion too.
Perfect. Any other questions from the judges? All right, so we will take one last 10-minute break. We only have 2 teams left before the judging and awards, but we'll see everyone back here in 10 minutes.
Okay, thank you. Thank you everyone for
All right, everyone, let's slowly get started again. Our next team is TMU Triage. TMU Triage, are you here and ready? Okay, TMU Triage, I'll invite you to share your screen. And you could go ahead and get started when ready. TMU Triage, are you here and ready to present? Maybe let's give them a minute or two as they're coming back from the break.
If there's a
TMU Triage, whenever you're ready, please do check in. Otherwise, we will have to skip you and go to our last team. Okay, maybe I'm mistaken, but I thought TMU Triage was supposed to present. It looks like we will be skipping to our last team. And that will be Hackers Not Slackers. Hackers Not Slackers, are you here and ready to present?
Yeah, we're ready to go. We just need to set up really quickly if that's fine.
Perfect. Take a minute.
Okay, thank you.
I can't hear anything. I don't know if somebody's talking, but I can't hear anything.
Yeah, Filippo,
Same
whenever
here.
you're ready, you can get us started.
Hackers, not slackers, whenever you are ready to go.
Hi, everyone. This is Team Hackers Not Slackers, and our solution is Triage to Go, which is an innovative solution reducing emergency department wait times. So we are Zaid, Tanzi, Philippa, Reman, and Chaten. So we're going to cover the emergency department structure, the Triage to Go solution, and how we're going to test it.
So an emergency department is what we can say like the most chaotic and spontaneous part of the hospital, made for people to just come in whenever they feel like they have an issue. When you feel like, there's something wrong with you and you need immediate care, this is where you go. So the first thing that happens is when you don't feel great, you have two options. You either get a ride to the hospital through your own means, or you call an ambulance to take you to the hospital. Now, when you get to the hospital, you get triaged or assessed to see how serious your condition is. This is done by highly trained and experienced triage nurses, where they then assign you a score from CTAS 1 through 5, where 1 is the most urgent and 5 is the least urgent. After getting your score, you then have to wait. If you have a CTAS 1 or 2, they'll probably be seen almost immediately, whereas CTAS 4 or 5 would mean that you'd be waiting for a while, depending on how busy the hospital is at the time. After waiting, you see a doctor who will do their diagnosis and assign a treatment. And after that, they'll either ask you to stay, depending on the severity of your case, or you'll be discharged and sent home. All right, perfect. Now we'll go over our solution, which is basically just redirecting patients to a primary care facility. Now we'll go over what the situation looks like as it currently is. All right, so the current system is essentially the individual will call 911, an ambulance reaches the person's house, and it'll transport them to the hospital, where they're triaged and then they wait for an assessment. In our modified system, this actually works by individual calls 911, and then when the paramedic reaches them, they'll actually connect them with a nurse using a web application, and then the nurse will triage them virtually. And then if they belong to a CTAS 4, a CTAS 5, the paramedic will determine the closest nearby primary care facility, and the individual will be dropped off at that place, and they'll get their care over there instead, and we'll redirect these patients. And now we wanted to actually base our solution on the stats, and what is a pie chart of CTAS 4, CTAS 5, and its discharge status. And you'll see that like the largest chunk with the largest blue chunk is people who are discharged without service support or referral. And basically, essentially, we believe that these people can be redirected to a primary care facility where they'll be seen faster. Like it's possible that they'll be seen early by physicians. And then it also increase patient flow in the actual emergency department because there's people. And one thing to note is that there is a small percentage that are admitted to a unit at the hospital. So essentially, we'd have to consider our exclusion criteria for which people are we not going to include in terms of who are redirected.
So now I'll walk you through essentially our web app walkthrough. And this is essentially what we came up with. It's an HTML, CSS application that we've essentially developed completely from scratch. You guys are welcome, and we encourage you to check it out at this link over here, hackersnotslackers.github.io. So I'm just going to open that up. And as you can see, when we open up the website, it takes us first to this navigation page. And on the navigation page is essentially an embedded map. And what we've done is we've loaded in some of the local clinics and hospitals in the city. The hospitals are in red and some of the clinics are in blue. So if we enable our location, then we can essentially see which areas are nearest to us at the moment. So for example, let's say that the ambulance goes to pick up a patient, the paramedic would enable his location, and they would be able to see which care facilities are the nearest to them and
the distance to which, how long it would take to get there. And they're also able to map to a particular location by clicking here. And the second aspect of this solution is on the video tab. Now, to essentially prevent me from having to join 2 Zoom meetings at the same time to represent a virtual triage, we've just prepared a video to showcase that functionality. So I'll just play that video now. Okay. Yeah, so I'll just narrate over essentially what's going on. I'm just joining the meeting right now. On the left side, I'm joining this meeting. So I basically just configure all of the meeting settings. So now I can join the call. And we have the nurse waiting there, and I would be kind of the paramedic in this instance. So at the same time as that, on the right side, we have a triage form. So on this triage form, it's a fillable PDF, so we can fill out all the fields inside of it. And that will essentially allow us to gather like normal triage information, profile the patient, determine their CTAS rating. And then on the bottom here, you can see we can actually press a clinic to choose, and we can send the information to that clinic and share that information with them. So it saves time for us, and it also saves time for them to be able to profile the patient. And that gives a lot of reason for this solution to be viable for clinics as well as us.
All right, so I'm going to go over how we're actually going to test our solution. Essentially, the first thing that we're going to do is we're going to have a 4-step process through which we test it. Essentially, we're going to start off small initially, and we're going to have very strict exclusion criteria. We're only going to work with select individuals who receive a CTAS score of 5, who are going to be redirected to a nearby clinic. And again, the idea behind this is that these people are lowest in terms of priority, so their care is like least urgent, and they'll face the least amount of detriment if anything goes wrong. And then the step is we're going to follow these people in terms of when they see a physician, how long that takes, how their treatment management goes, as well as the overall outcome of their stay. And then step 3 is where we're actually going to review our exclusion criteria. So if step 2 is successful, then we're going to start including more and more people. And if it's unsuccessful, if there's some sort of problem, we're going to revisit our exclusion criteria and be like, should we be including these people? And essentially, once this ends, at step 4, we're hoping to include the majority of people who receive a CTAS score of 4 and 5, and they'll be redirected primary care facilities through our web application. And then the second thing we actually wanted to test was whether we could actually reliably triage people over video call. And through this, we've designed an experiment where we have 2 nurses. So one nurse is physically present and one nurse will be present over video call. And this is obviously going to take place at the emergency department. And first, either nurse will triage the patient first, and they'll receive a triage score with that nurse. And then the second nurse will triage the patient as well. And they'll compare their scores to see how they're different and if they're off by any margin. What we'd expect, our hypothesis is that they'd be the exact same, as research shows that virtual triage is not too much different from physical. And of course, the paramedic is present to take any physical signs that is needed. And that'll be our solution testing.
So in conclusion, emergency departments are crowded as well as short-staffed in terms of clinical personnel. So redirecting patients could significantly improve the system as well as alleviate challenges with resources. So we are proposing a novel solution, which is triage to go. And the overall impact would be improved patient outcomes, prioritization of patients that need care the most.
Yep, thanks for listening. We'll take questions now.
Excellent. So I think, Jan, you're trying to ask a question, but we can't hear you. You're not muted, but
embed.
Oh, go ahead, Jan.
How's that? Can you hear me now?
Perfect.
Okay, sorry. The logistics of the solution, I was trying to understand. So the triage, the scoring triage is happening by Zoom. Is it with an emergency medical tech and a patient zooming with a nurse? Can you re-explain a bit how it's happening and who's filling up that PDF?
Yeah, all right, perfect. So I'll just go over how it works. Essentially, what we want is that when the paramedic arrives, they're going to have a tablet with them, right? And then on this tablet, they're going to connect over video call with the nurse that's going to be doing the triaging. And of course, the patient is the one that's going to be on video call with the nurse, and the nurse will actually fill out the form. But like the patient can also see as the nurse fills it out. Like it's visible on the website as it's being filled out. And then again, if they get a triage score of like, let's say 4 or 5, then the paramedic will decide to redirect them to the nearest clinic. And then if they, of course, they have the triage score of like 3, or if they like fit any of the exclusion criteria, then instead they'll just take them to the hospital as regular procedure. Does that answer your question?
Yes.
Yeah. So the problem you're solving is then patients who call ambulance but end up having a low triage score, right? Because patients who don't call an ambulance would never interact with your system.
Yeah. Essentially, at this stage, that is what we are targeting.
That leads me, so it's a question more than a general question. Why would then the EMT or EMS person, why would they not do the triage themselves? What are they missing that the nurse has? Is it equipment or is it a specific algorithm? Like the Zoom seems like an additional complexity here, even though it solves the problem.
So I think to answer that question, we have to look at perhaps why triages are not already being done inside of the ambulance by paramedics. And part of that has to do not with the fact that EMT are not trained enough. We know obviously that they are medical professionals and they are able to do something like that. It's just that extra layer of security that everybody is used to getting triaged by a nurse, right? And maybe somebody might not feel comfortable just being triaged by and profiled by just a paramedic. So it adds an extra essentially aspect of reliability. It improves the trust that the patient has with the medical personnel, and overall just like to emphasize the point that it tries to take something that is already being done, which is triaging with a nurse, and bringing it to a virtual space. So does that answer your question?
Yep.
Any other questions from the judges? Okay, well, thank you so much. That is our last presentation of the day. So at this point, we will sequester the judges in a breakout room and they will deliberate. Shouldn't take too long. So everyone, please stick around and stay tuned. And we'll be back with the final awards. So I will create the breakout rooms now.
Hey guys. Oh,
not quite there yet.
No,
Okay, we're welcoming everyone back into the main room. I'm going to share my screen. So the deliberations have concluded. I can let you know it was a very tough decision, and actually we will be awarding more prizes than initially planned. So there will be 5 total awards, 5 teams taking away prizes today. Before we get to the final announcement, I'd like to let Jan Fossat give a few closing words.
So first of all, I want to thank you all for the work you put in here into those presentation and ideas. It was really fun to see and hear your thoughts. I also want to congratulate you on the slides. Look really cool. The team names are amazing. And talking to the physician in the judging team as well is generally you had a good handle on the problem, which is not easy from an outside point of view. It all seems like, oh, this is complicated. It should be fixable right here. But medicine, the emergency department, electronic record system, all of that is insanely complicated. So congratulations for tackling something that difficult. And like Jesse said, it was not easy. So that's it for me.
Prashant, if you also would like to say something, please.
You're on mute.
Sorry, no, I agree with Yana 100%. It was a pleasure listening to everyone's solutions. You know, it was in many ways a very big problem, a wicked problem, and I think a lot of the groups did a really good job of trying to narrow it down onto a specific part of that big problem and come up with something that's you know, actionable and testable. So congrats! Like it's you know, having lived in this world for 15 years, it's a very complex space, and I think you guys all did a great job of trying to understand it in a very short time.
Excellent. Thank you so much. Thank you to the judges. Thank you to the mentors and to our guest speakers. On behalf of the whole MedTech team, thank you to all the teams for your excellent work. So without further ado, I will present the awards. All right. In third place, there are 2 teams who we have decided to make the award for. You will each get the full amount to split amongst your team members. So in third place, Team 2, Caduceus, and Team 21, Hackers Not Slackers. Congratulations. Okay. In second place, again, we have 2 teams who are going to take second place. Again, each team will get the full prize amount. So without further ado, second place, Team 5 ER Hack and Team 3 Code Blue Crew. Congratulations. All right, and the anticipation is building for the first place announcement. Okay, virtual drum roll in the background. First place and sole position of first place belongs to Team 8, Les 5 Hacketeers. Well done. Excellent job to our first, second, and third place winners and to everyone who participated today. Really thank you for an excellent 3-week event. If there's any further pursuit of these ideas that you want to take to the next level, please don't hesitate to contact us. We'll put you in touch with anyone you need to be put in touch with. This was really a fantastic event. I want to thank everyone once again, and a special congratulations to our award winners today. So another virtual round of applause for everyone. Okay, and this brings this year's hackathon event to a close. On behalf of the MedTech Talent Accelerator, thank you everyone, and we'll see you next year.